Thank you. Good morning, everyone. I'm Michelle Consolazio with the Office of the National Coordinator. This is a joint meeting of the Health IT Policy and Health IT Standards Committee. This is the Public Health Task Force, and we are having a hearing today. So welcome to everybody, and thank you for those of you who are in the room. We're working on the lighting, so there's a little mood lighting right now. It's a good balance between the screen and being able to see, so we'll work on that. But let's get started by doing roll call, and we'll start with Noam and go around the room.
Noam Arts from HLN Consulting. Good morning.
Good morning, Janet Hamilton from the Florida Department of Health.
I'm Steve Hazley. I'm from the American College of Obstetricians and Gynecologists.
Good morning. I'm Anjum Khurshid from Dell Medical School, University of Texas at Austin.
Julia Gunn, Boston Public Health Commission.
Richard Loomis from Practice Fusion and the EHR Association.
Susan McBride, Texas Tech University Health Science Center.
Ricky Merrick, Association of Public Health Laboratories.
John White from the Office of the National Coordinator for Health IT.
Kathleen Blake with the American Medical Association, but also co-chair of the Health IT Policy Committee. So I'm looking forward to today's discussion.
Jim Daniel with the Office of the National Coordinator for Health IT.
Good morning. I'm Margaret Lampe from the Centers for Disease Control and Prevention.
Hi, I'm Rachel Abbey. I'm with the Office of the National Coordinator for Health IT.
Lee Stevens, ONC.
Sanjeev Tandon from CDC.
And on the phone, we have Larry Wolf. And our other co-chair, Annie Fine, is on her way. She's had a few commuting troubles this morning. So I just want to make a few announcements, just reminding everyone that this is a public meeting. So please state your name before speaking, as this meeting is being transcribed and recorded. Even as we go through the panelists, and I'll remind you all later on, if you're asked a question, if you could just state your name again before speaking so everybody knows who's talking. That would be appreciated. And before lunch, and then at the end of the meeting, we will also have time for public comment. Just a reminder for our public commenters, public comment is limited to 3 minutes. And I think that's everything. So I'm going to first turn it over to John White to make a few opening remarks.
Great. All right. Thank you, Michelle. And thank you. Good morning, and thank you to everybody that's here and everybody that's on the phone. I and my colleagues at ONC are extraordinarily grateful for your presence and your service and your attention to a really important topic. So I'm here as the Acting National Coordinator for Health IT. In real life, I'm the Deputy National Coordinator for Health IT, but I will be serving as the Acting Coordinator until we get a political appointee. So very proud and pleased to be able to lead my amazing colleagues at ONC, super good people, working on super good stuff. So I'm really pleased to be able to welcome you to this joint Public Health Task Force hearing and work. This is a really critical issue. I know that you all have your own personal interest in it, but you know, as a public servant who looks across the health of the nation and tries to understand what's happening and identify, things that are going well and things that are risks. This is a significant issue for us as a nation and really for the world. So we are really looking forward to hearing your feedback on the important topic of the intersection of public health and health IT. Although ONC has a long and storied history with bow ties, I am wearing my bow tie today in commemoration of what I used to do clinically before I became a public servant. So while I am not an obstetrician gynecologist, I am a family doctor, and where I was practicing in Lancaster, Pennsylvania, we did a lot of deliveries. And I loved taking care of pregnant women and their families. We worked very closely with a group of obstetricians. It was a great partnership on an ongoing basis. And I reflect back on my time providing obstetric care with gratitude because I never had a bad outcome, and also because it was really it's a special time in people's lives, and it's a really amazing place to be involved with, and pretty cool medically speaking. and it's, it just, kind of, all the more poignantly highlights, the issues associated with Zika as the particular, fire that has been burning recently, around the world. Of course, pregnancy status is really important to be able to capture in Health IT, but it's been brought to the forefront, right, by the emergence of Zika. It affects a really large number of folks. The full impact and the epidemiology of this disease is not very well known yet. We have, some handle on it, but we're still learning a lot as we go along. And frankly, this is really one of the reasons, although we didn't know at the time, why we've built a health information infrastructure, is to be able to tackle issues like this and to be able to understand them better and to address them quickly and effectively. This is where sometimes we devolve into, tech geekery, and we say, well, standardized capture of information is really important for this, but it is. Again, as a guy, who used to get a lot of blood on his shoes, but who also, loves his information systems, this is really important, for the women and the children and the men and the families that are, affected by this, and really for all of us. So when you get down to the standard capture of pregnancy status in electronic health records and other health IT, and being able to identify best practices around exchanging that pregnancy status from one information system to the other, in the interest of helping streamline, improving care, it's critical. This is why we focus so heavily on interoperability and standardization of information, because it really is critical, not just to be able to get your information system right, but for people's lives. So, long term, we hope that we can use Zika as a use case to explore the use of automated clinical decision support. We think this is, again, one of the significant promises of our information systems and our tools, is that you get the right information in front of the right people at the right time in the right way, so the right things happen. We're looking forward to looking at Zika as a use case for electronic clinical decision support as well as electronic case reporting. Ideally, some sort of solution, we'll find ourselves at beginning stages of a solution in the next few months. The disease is out there. This particular disease is out there, continues to spread, continues to be a problem for significant portions of our population. And I'll tell you, it's not going to just be Zika. Okay, this is what's happening now, and it's important. There will be other things like this. So this is you're building foundations when you do this. You're building on foundations, but you're building foundations for future work as you do it. So please take it with that perspective. There are currently some other activities underway, including several excellent webinars with our colleagues in the developer community. Want to emphasize to you that we are, coordination is in the name. We are very carefully coordinated and intentionally coordinated with our colleagues at the CDC. I'm going to take the opportunity to ladle gratitude and superlatives on the head of Sanjeev Tandon, who is here with us today from the CDC. Over the years that we've been working with Sanjeev, I cannot begin to tell you the value that my team places on their working relationship with Sanjeev and his colleagues. You have been an amazing colleague for us and partner, so thank you very much for everything that you have done and that you will continue to be doing. So thank you. So with that, I've rattled on long enough. Thank you for listening to me. Thank you for your work, and look forward to hearing the feedback that you have for us.
For Larry today? Right. I'm sorry, we don't have Annie in the room. Jim is going to make a few comments, and then we'll turn it over to Larry after Jim.
Thanks, Michelle. So, yeah, Annie, I think, is still on her way from the airport due to some issues this morning, so I will try to channel some of Annie's energy for some opening remarks. We're really excited to have everyone here. As Dr. White mentioned, this has been a real collaboration with the CDC. We could not have done this without our partners, Margaret Lampe in the Zika Emergency Operations Center and Sanjeev in their informatics unit. So, all of this work has been a true collaboration with CDC. And I'll say that we asked this task force to do a lot. I mean a lot, in a really short amount of time. We asked you to come up with recommendations around pregnancy status. We asked you to look at standards for clinical decision support. We asked you to look at the clinical workflow and public health follow-up and how all of that can really incorporate into the clinical setting and how information can really be exchanged between public health and the clinical setting and the EHRs when necessary. So we know that's a lot, and we know we gave you a very short period of time to do that. We have tried to really prioritize some of the issues, and I think during the day today, you'll hear us trying to bring back those priorities as we focus as some of the questions get focused around the recommendations around pregnancy status, and really making sure that we can leave this task force with some clear recommendations around what pregnancy status should look like from a standard setting in the EHRs. And we know that some of the other issues are extremely important, and we might not get to clear-cut recommendations around standards or what the ONC should do with some of those issues, like the standards for clinical decision support and supporting the workflow for the interactions with public health. But I think there's some recommendations around the solid actions and other things that we need to look at to make sure that in the future we can make those recommendations. So as the day plays out, I know Annie would have said this, so I will say it on her behalf, that she will be trying to focus some of those conversations to make sure that we do meet our priority issues. And I just want to thank everyone for coming here. The task force has been amazing to work with. I think we've got a really excellent group of panelists coming up for the hearing today. We're excited to hear from everyone.
Thank you, Jim. Larry, do you have any other remarks you'd like to make?
Sure. Well, I'll add to the thanks to everybody, to the task force members and to the panelists for the time that they've already given us, for their expertise, for the written materials that have been supplied, and for the discussions that we're going to be having today. These hearings are a very effective way for getting a lot of information shared and communicated, and not just out there as a one-way stream, but really to encourage dialogue. And so with that, I'll add one tiny bureaucratic reminder. I know the panelists have a tremendous amount to tell us, but as we go through your initial presentations, to really stick to the time limit and think about really the most important one or two things you have to tell us. I know you've got a lifetime of experience to communicate, but really, what is the most important thing that we should be hearing today? We'll have time to expand on that in the discussion that follows. And by really putting everyone's point of views out there, we'll be able to get the most robust picture. So think about that. Really, what is the point of view, the unique position that you bring to us that you could help share with us today? I expect, even though there are going to be a lot of individual points of view, there's going to be a lot of common threads here across the panelists and across the panels. So these will inform our recommendations to the Health IT Policy and Health IT Standards Committee, and then through them to the Office of the National Coordinator and the larger federal establishment. But also, this really becomes a place where we as members of the industry get to come together, and the recommendations that come out here really have much broader reach than just things that wind up in government regulation. And then finally, a comment about the timing of this hearing. Yesterday at the Health IT Policy and Standards Committee's joint meeting, we spent a lot of time reviewing the current interoperability standards advisory. And there are a lot of elements in there about things that have been standardized, of standards that are coming into adoption. And as we look at our recommendations here, I think we'll be looking to frame them in the context of those larger sets of standards that are out there. Looking for places where we can build on what's already in place and where we need to extend what's already there. So I think it's going to be a really very exciting day. I wish I could have been with you guys live in D.C., but it just didn't work out. And I'm looking forward to the discussion. Thank you.
Thank you, Larry. So I'm going to just go over a few logistical things before we introduce panel one. Just to reiterate what Larry said, we have a very tight agenda, and some folks are calling in, so we're going to try and stay as close to the agenda as we can, which means please try to stay to the 5 minutes that you've been allotted. There will be a timer up on the screen, not to make you nervous, but just so you have an idea of where you are. And as you get close to the 5 minutes, I will let you know to wrap up your remarks. And then if you go over, I will ask you to please move on. But please know that if you don't get to say everything, that we are going to ask you questions, and you'll likely be able to share that additional information in those questions. To our task force members, after each panelist goes and shares their 5-minute remarks, you will have the opportunity to ask questions. You can put yourself in the queue by raising your tent card. And for those on the phone, there is a little hand-raising feature that you can use, and that will also put you in the queue. So we'll just go around based upon who raised their hand first and ask questions. And again, a reminder to our panelists, as you are asked questions, if you could state your name again before responding, that would help all of us. And so thank you all for joining us. And I will ask you all to introduce yourselves. Oscar is not here yet, so we will put him to the end of the panel, unless that is him walking in right now. Okay, so we are good. So if each of you could introduce yourself so I don't butcher your names, and then we'll start with Aisha to do your remarks.
Aisha Haney, Harris County Public Health.
Shauna Webster, Executive Director of NAFCIS.
Oscar Allen, National Association of County City Health Officials.
Good morning, Charlie Ishikawa, Executive Secretary to the Joint Public Health Informatics Task Force.
Hi, good morning. I'm Mary Ann Cooney. I'm from the Association of State and Territorial Health Officials.
And on the phone, we should have Emily Peterson.
Hi, yes, I'm here.
And Jillian Haney.
Hi, yes, good morning. Jillian Haney from the Massachusetts Department of Public Health.
Okay, so thank you all, and we're about to get started, so please, yep. And we have Annie now, yay! And also, just before we get started, within the agenda, there are the questions that we've asked of panel 1, and it will also get displayed as well. So just for our task force members, if you're wondering what they're responding to, just a reminder, we'll be there. Okay, now we're ready to get started.
Okay, good morning. Harris County Public Health is a local health department for Harris County, Texas, the third most populous county in the nation. Our jurisdiction includes approximately 2.3 million residents living in unincorporated areas of the county. We provide comprehensive public health services to over 100,000 individuals annually through our 17 wellness clinics and WIC centers. Since January 2016, when our department reported Texas's first Zika infection in a traveler, we have confirmed 39 Zika infections, including 2 infants with congenital disease. Our epidemiologists have evaluated over 800 individuals for Zika, assisting with testing and providing guidance. The majority of those evaluated have been pregnant women. This said, capturing pregnancy status and fully utilizing data integration and informatics to mitigate health risks in our community is of paramount importance to our health department, especially given our geographic vulnerability to Zika as a relatively warm Gulf state that has already experienced local transmission. And although Zika has gained significant media attention, other communicable diseases such as HIV and syphilis also stand to gain from improving technology infrastructure and promoting the development of pregnancy-related clinical decision support tools. Pregnancy status is captured routinely within our health department for both clinical and epidemiologic surveillance purposes. In our clinics, it facilitates family planning, safe prescribing, disease prevention counseling, and referral to ongoing care. For surveillance, pregnancy status allows us to gauge community risk posed by diseases such as Zika. As in many public health departments, the majority of our pregnancy screening documentation occurs on paper, which is then scanned into our electronic health record system. We have limited ability to input pregnancy-related information directly into our EHR and lack clinical decision support functionality and information exchange technology. Public health would benefit from affordable, universally accessible, robust EHR systems that satisfy meaningful use Stage 3 criteria with clinical decision support technology, linkages to public health and registries such as the Texas Birth Defects and U.S. Zika pregnancy registries, laboratory integration, and e-prescribing. Beyond our own direct clinical use of such systems, our ability to perform population disease surveillance depends upon our busy community providers being armed with tools to appropriately screen and evaluate patients for Zika and other high-consequence diseases, and then communicate information to public health in a timely fashion that facilitates early response. In our community, 2/3 of confirmed Zika infections have occurred in individuals of Hispanic origin, a demographic that tends to have fewer resources, often relying upon safety net providers with limited access to advanced EHR technology. Equipping safety net providers with robust EHRs would facilitate provider communication with public health and also offer secure linkages to the care continuum, including hospitals participating in the care of a pregnant patient. Integrated clinical decision support technology could remind providers to screen females of childbearing age for pregnancy and Zika during all clinical visits, order prenatal labs, and provide Zika testing guidance. For purposes of Zika surveillance, initial public health disease reporting from a community provider, hospital, or laboratory ideally includes pregnancy status, last menstrual period, dates and locations of relevant travel or sexual exposures during the pregnancy and 6 months prior to the pregnancy, symptoms, demographics such as age, sex, race, and ethnicity, and type and date of Zika test ordered. The importance of assisting community providers, especially those serving low-income Hispanic populations, in the adoption of advanced EHRs facilitating screening and public health communication cannot be overstated. Our epidemiologists continue to encounter too many missed opportunities in our community with regard to Zika. Pregnant women with travel exposures who are tested outside of the recommended time frames or not at all prior to delivery despite being in care. Those who are not rescreened for Zika at subsequent prenatal visits or who are tested for Zika but with the wrong test, delaying and sometimes precluding an accurate diagnosis. Much of this is likely avoidable with the right tools. In sum, clinical decision support tools and enhanced public health data integration would greatly assist public health departments mitigate risk to pregnant women and those of childbearing age in our communities. We believe that policies and funding should support universal access to advanced EHR infrastructure because this is absolutely critical to beating Zika and other communicable diseases that threaten the health of our next generation. Thank you.
Thank you. Shauna?
Good morning. My name is Shauna Webster. Again, I'm the Executive Director of NAFCIS, the nonprofit association of vital records offices in all 57 jurisdictions in the country. Thank you for including us in this discussion. Though most of the questions and responses today will deal with how information is related to a pregnancy, Zika and other emerging infections always place greater demands on the data captured on the birth and death certificates as well, so I'm here to speak from that perspective. The collection of vital records, including information on births, deaths, and other events, is the legal responsibility of the states, not the federal government. Vital records and their data are collected and owned by the states, and although we might promote a national standard, the reality looks very different state to state. For instance, it has taken over 15 years for the bulk of our 57 jurisdictions to use the 2003 standard birth certificate. We're currently at 56. Changing how or what gets captured on the birth or death certificate is a long and expensive proposition. And that's only one part of the system. The process for registering vital events, preparing the files, and releasing the statistics data is extremely complex, with many steps performed by many actors from start to finish. Since we have limited time today, I want to focus on just 3 of those major challenges. First, electronic systems themselves. The electronic birth and death registration systems in each jurisdiction represent an enormous amount of time, work, and money that in most cases had to be paid for and developed by the state itself. Not only are the systems different in every state, but each state has progressed, or not, on different timelines based on the availability of their own resources. Information needed to address Zika and other emerging infections has to be coordinated within those financial and structural limitations. Vital records rarely receive additional funding for these new or enhanced demands for data like some other programs do. Solutions would include a more sustainable funding source for all state electronic systems infrastructure, which would benefit all of us here today, and also being able to use the existing data fields in the EBRS and EDRS to capture new types of data without changing the system itself is critical. So number 2, the issue of capacity. Vital Records Agency personnel help train the data providers, so the physicians, the nurses, the coroners, medical examiners who use these systems. And we look to CDC, the state EPIs, and other partners to help inform and direct collection of special indicators, whether it be disaster-related or the disease du jour. But state personnel is limited, and so are the funds to support these training efforts. The reality is that many jurisdictions lack the capacity to respond to increasing demands for more timely data. With dwindling staff and hiring freezes the norm in many states, our offices don't have the human or technical capacity to fulfill these needs. One of the other problems is that turnover and lack of experience with our data providers, especially the nurse level, is an ongoing challenge. Number 3, sort of the lag time in official guidance. Though NAFSIS and its partners work closely with CDC and other federal agencies, guidance as to how to record information related to these events or diseases takes far too long to be processed, approved, and disseminated. It also requires much greater coordination between federal agencies than currently exists. Once the guidance is finally made public, states need time and resources to implement changes. Though it's tempting to rely solely on an EHR, a properly resourced Vital Records Agency could share the data faster and with far greater accuracy. In conclusion, I just want to reiterate that NAFSIS and its members, its electronic systems, are poised to be the solution for real-time public health data exchange, especially in times of crisis, but our member agencies can't fully participate in these systems without adequate and sustainable support. Thank you.
Thank you, Shauna. Oscar?
Good morning, everyone, and thank you for giving us the opportunity to share perspectives on behalf of the National Association of County and City Health Officials, otherwise known as NACHO, and local health departments regarding the availability, standardization, and transmission of pregnancy status in electronic health records. My name is Dr. Oscar Allen, and I am the Senior Advisor for Public Health Programs at NACHO. NACHO's vision is health equity and security for all people in our communities through public health policies and services. Our mission is to be a leader, partner, catalyst, and voice of local health departments. And as a national organization representing the nearly 3,000 local health departments across the United States, we strive to help improve the public health system at the local level. Throughout more than 20 years of program development, evaluation, and continuous quality improvement, we've been the best and the most reliable source of information about and for our local health department. And recognizing the broad reach to engage local health departments through their national leadership and capacity building assistance. So we strive to strengthen local health departments by building that capacity, and this level of support is important for and critical for improving health of our communities. Now, I cannot underscore one point enough. Local health departments are at the front lines of public health. And with that said, they must rely upon accurate and timely and complete information. If you may permit me, as we are focused on Zika, there's no doubt that the role of local health departments have played in addressing that disease, which include preparing for potential cases of infection in their communities, conducting surveillance for mosquitoes and Zika infection, implementing vector control measures, communicating to the public about ways they can protect themselves, and supporting healthcare providers by providing recommendations, coordination of testing, and following up with individuals with suspected and or confirmed infection. My colleagues in this room permit me the latitude to not speak to you in terms of incidence rates, p-values, and statistical significance. Permit me to explain to you what local applied epidemiologists across this country have and continue to do in preventing and responding to threats like Zika. They have the duty of intimately knowing where people are that are infected or may have been exposed. They, with their communicable disease control and public health nursing staff, have the experiences of talking to patients, their families, about their health, explaining complex scientific terms into compassionate, everyday language for their understanding. They have to be able to predict where diseases are going to be spread, and more importantly, work together as a team to minimize as much of the impact that can occur with outbreaks like Zika. This is no easy task, and health information technology approaches or solutions, while critical to easing these burdens, cannot fully replace good interviewing skills or generating the important outcomes from it. At the local health level, as was indicated by my colleagues from Harris, they must rely on accurate and timely and complete information, executing interventions that make sense and can provide the best line of defense to these growing threats. Zika is no normal run-of-the-mill virus. We saw sexual transmission in a climate where sexual transmitted diseases are already a problem. We also saw the horrendous consequence of birth defects in our next generation. So to answer the question on relative to pregnancy status, what are a minimum and optimally what does public health need to know? At minimum, there needs to be demographic information and enough details that enable local health departments to follow up with an individual if needed. Electronically conveying even minimum data sets has been a challenge. In one jurisdiction, most of the Zika testing was done by reference labs. And there's been consistently, and to their experience, little or no identifying information beyond the lab test and name. So critical information, such as the healthcare institution who is requesting the test, the contact information for the patient, are commonly absent. So transmitting pregnancy status with laboratory orders could improve the inclusion of obtaining minimum demographic data with every lab report, regardless of where that lab is. This would save public health substantial time and work for not having to follow up with reference labs to obtain basic information. And additionally, whether or not we're speaking about estimated date of delivery, which will help time with levels of concern in the window in which you are able to execute your interventions, travel history, immunizations, demographic immunization, all data points or variables of fields that we collect across the spectrum of pathogens. And these elements should be easy to pull and access. NACCHO and local health departments recognize that we as stakeholders consider what public health optimally versus at a minimum needs to know regarding pregnancy status. The task of extracting those data sets from the EHR and transmitting it quickly becomes complex and cumbersome. So, not to belabor the point, but as we talked about what needs to be captured across the continuum, we find that some local health departments have to deal with multiple systems for that data capture, which poses significant challenges to their already strained resources, as was previously mentioned. If people receive direct services from a local health department, they're also considered public health clients, and as a result, their data should go into the local health department's EHR. One problem: most local health departments do not have EHRs, and were excluded from the opportunity.
Please wrap up.
Time up?
You can
Okay.
wrap up.
So, with that said, information requirements constantly change and needs flexibility. Public health has been a major component in this response, and we ask that we essentially, and you as your colleagues, make recommendations that are applicable, flexible, and reliable for what is needed at the local level.
Thank you, Oscar. We have Emily on the phone.
Good morning. My name is Emily Peterson, and I'm the lead of the U.S. Zika Pregnancy Registry. I'm representing our experiences in Zika virus and pregnancy and birth defects response, as well as what I'm hearing from our wonderful state, local, territorial, and tribal health department partners. Next slide. CDC established the U.S. Zika Pregnancy Registry to monitor pregnancy and infant outcomes following Zika virus infection during pregnancy. As you know, at the beginning of the outbreak, we knew very little about the effects of Zika virus infection during pregnancy, and data from the registry has informed clinical guidance and directed emergency public health action. The registry is a supplemental surveillance effort coordinated by CDC, and CDC collaborates with state, tribal, local, and territorial health departments to collect data on pregnancies with laboratory evidence of Zika. Health departments identify pregnancies with Zika through laboratory testing for Zika and reports from healthcare providers. The health departments then work with providers to collect data on maternal health history, including prenatal imaging and tests, neonatal assessment at delivery, and infant follow-up of physical exam findings, developmental assessment, and imaging at 2, 6, and 12 months of age. The health departments then report these data to CDC. Next slide. Incorporating public health pregnancy status into electronic health records and lab reporting would improve the U.S. Zika Pregnancy Registry. When the registry and the response to Zika virus first started, health departments were easily able to identify pregnancies with Zika because all testing was performed or coordinated through health departments, which consistently identified pregnancy status. Zika testing has now expanded into commercial labs, and health departments receive Zika testing results from these labs, but the results do not consistently identify the pregnancy status. Thus, identifying pregnancies with Zika has become more difficult. If pregnancy status was available on commercial lab results, identification of pregnancies with Zika would be more efficient, and more consistent follow-up and referral to care of pregnant women and infants could be prioritized and thus be more timely. We are concerned that participation, timeliness of reporting, and complete reporting of pregnancies with Zika to the U.S. Zika Pregnancy Registry will decline without pregnancy status reporting. This would lead to less data to understand Zika and pregnancy in the United States, resulting in a potentially less informed public health response. Next slide. You can help the U.S. Zika Pregnancy Registry and our understanding of Zika and pregnancy by enabling easy data capture of pregnancy status and key components such as estimated delivery date in the electronic health records. This will help improve clinical care and our collection of clinical data and improve our management of laboratory results for Zika virus testing. Clinical decision support tools such as screening for Zika virus exposure in electronic health records will also help to ensure appropriate pregnant women are tested. This will help CDC's emergency response to Zika, as well as facilitating protecting pregnant women and their infants in future emergency responses and emerging public health threats. Thank you.
Thanks, Emily. Charlie?
Great. Good morning, ladies and gentlemen. Thank you for the opportunity to inform your developing health information technology policy and standards recommendations for Zika preparedness and response. In response to your questions, my remarks draw from input from the Joint Public Health Informatics Task Force, JPHIT. JPHIT is a coalition of 10 public health associations and 4 partner organizations that help governmental agencies build and enhance informatics infrastructure for public health assessment, policy development, and assurance. As JPHIT's executive secretary, my role is to facilitate and communicate a complete and unified perspective. Pregnancy data are routinely used for public health to protect and improve maternal, prenatal, and infant health. These data are needed by immunization providers, public health surveillance professionals, maternal and child health professionals, and public health epidemiologists and researchers. Given these use cases, better and more accessible pregnancy data will make our communities more secure and resilient to present and future health threats. Looking across these use cases, it appears that the essential element for pregnancy status that public health needs is pregnancy status. Yes, no, maybe, or unknown. And the minimum data with regard to a pregnancy seems to be gestational age, expected delivery date, and pregnancy end date. Optimally, these pregnancy-related observations would be made for all women of childbearing age, remained current, persist beyond the end of pregnancy, and be linkable to mother and infant test results and health outcomes. Currently, data on pregnancy status are captured by multiple parties and at multiple times along the continuum of care. Those data may be based on direct clinical and laboratory observations and may be inferred from data such as a provider's medical or surgical specialty. Pregnancy status information presently appear in standards-based syndromic surveillance data, immunization information system records, and all payer claims databases. If new processes or standards are introduced for capturing pregnancy status data, then it is important to consider how any change would impact the quality of those data that public health and healthcare professionals currently receive and use in the absence of the data they need. Enabling authorized parties to combine or link pregnancy-related data from multiple sources would be a win-win for patient, population, and public health care. For example, a growing number of states and other health care organizations are using an episodes of care methodology to analyze conditions or illnesses of interest, such as pregnancy, using computerized algorithms that look across claims and encounter data sets. Imagine how using those techniques and data sources in combination with public health reporting data and vital statistics data could fill in important information gaps. There would be an opportunity to look at a single case longitudinally and episodically across multiple settings of care. From a public health perspective, automation for clinical decision support would help in assuring the best patient care for Zika, and the automated processes should be architected in ways that can be useful for both emerging and routine public health threats. The requirements of immunization information systems for CDS are helpful in understanding the automation needs. In closing, please consider placing the following two contingencies on your recommendations to the Health IT Policy and Standards Committees. Number one, state and local public health informatics infrastructure needs modernization and greater human capacity for our nation to fully benefit from better and more timely pregnancy status data. And number two, public-private partnerships like the Digital Bridge will be critical to working out implementation details that are mutually beneficial for all parties. On behalf of JFIT, thank you for your dedication to our nation's health. We appreciate your leadership and commitments of our clinical care and vendor parties for health IT that improves and protects both personal and population health. JFIT stands ready to work with this joint task force moving forward.
Thank you, Charlie. Mary Ann?
Good morning, everyone. My name is Mary Ann Cooney, and I'm from the Association of State and Territorial Health Officials, and it's a great honor and privilege to be here today. ASTO is a national nonprofit organization representing public health agencies in the United States, the U.S. territories, and insular areas, associated free states, and the District of Columbia, and over 100,000 public health professionals these agencies employ. ASTO members, the chief health officials of these jurisdictions, formulate and influence sound public health policy and ensure excellence in state-based public health practice. With the Centers for Disease Control and Prevention, ASTO works closely with state and territorial public health to assure their readiness and ability to prevent, respond, and mitigate exposure to Zika virus. This brief testimony is in response to the questions posed by the ONC Public Health Task Force, and while not a thorough landscape analysis or reflections of all states and territories throughout the nation, these comments will address three key areas: the critical interest of state and public health in collecting timely pregnancy status data, state and territorial public health current availability of pregnancy data, and state and territorial public health and clinical decision support. The value of collecting pregnancy status and surveillance data is clear. Public records, maternal, perinatal death, and infant mortality are considered essential in documenting key aspects of population health. Timely collection of detailed pregnancy and birth data differs state to state. State public health departments must be resourced, however, with workforce and technology capabilities to optimally collect pregnancy data beyond what they collect now. As an example regarding pregnancy status monitoring and evaluation, a question may be asked: at what time in the pregnancy was pregnancy status clinically determined? Maternal and fetal health relies on information about when pregnancy was determined. For some chronic or infectious diseases or conditions, the time of pregnancy determination would have no relevance. In the instance of Zika, this determination of pregnancy can initiate a set of policy, responses, and clinical actions that, when reported to state and territorial public health, take place and offer additional knowledge for surveillance and data research. Assuring health equity for prenatal care, especially in the areas at greatest risk for Zika, including rural and designated provider shortage areas, is important. Rural communities pose challenges where access to early prenatal care is critical but difficult. Mobilization of resources must be coordinated with local public health, and in the areas where local public health is similarly resource challenged, state and territorial public health may need to serve as the lead agency to develop the response policies, plans, monitoring, and surveillance approaches while closely coordinating with their local public health partners. State and territorial public health current availability of data. Strong relationships with healthcare and public health would greatly benefit from newer technologies for bidirectional electronic case reporting, where electronic health record and public health entities can exchange both timely and efficiently. Simply, it would be helpful to know if a woman was pregnant or not. Currently, our surveillance relies on delayed reporting of birth, fetal deaths, and maternal mortality, and these data exclude women whose pregnancy did not end in a live birth, reported stillbirth, or maternal death. For example, maternal mortality case findings is challenging, and women whose cause of death was not related to obstetric causes, who lack a link to the live birth or fetal death record, and whose pregnancy status is unknown, are lost to surveillance. Current automated data has several layers: lab reporting, birth, stillbirth reporting, and birth defects data. Zika status and pregnancy status are of interest in all these areas, and we are working to add Zika exposure information to the HL7 birth and birth defects reporting. And finally, public health departments are challenged to keep pace with technological advances. Further, the proliferation of new data sources like the electronic health record are usually unavailable to them. Only a few states have the ability to leverage the data opportunities to work more effectively. You've heard about Digital Bridge and the bidirectional data exchange, and these are critical. Finally, state and public health agencies and their leadership are strong advocates for these newer technologies, not simply for better access to care or data, but more to ensure the health of their jurisdictions. Additional resources are essential, partnerships with vendors are essential, and one need only speak with a health official who has been faced with the realization that one family within his or her territory or state has to experience the pain and suffering of having a child born with Zika-related birth defect to know how critical these system improvements are. We can and must do better, and enhancing our ability to prevent these occurrences is our collective responsibility.
Thank you, Marianne. And finally, Jillian.
Good morning, and thank you for the opportunity to speak before you today on behalf of the Commonwealth of Massachusetts. Capturing pregnancy-related information in electronic health records to support response activity has broad appeal across public health. Today, I will speak specifically with regards to its applicability for infectious diseases. My comments will be limited to the specific questions focused on public health need or response. Zika virus is the driver for initiating this discussion, and the public health need to identify infection early in pregnancy is critical and has been clearly documented and cited. I would like to state for the record that there are many additional infectious diseases posing serious threats to women and children's health where public health and clinical intervention are necessary. Rapid identification of pregnancy status prioritizes follow-up activities, improves surveillance, and ultimately prevents further spread of disease. These diseases include, but are not limited to, hepatitis B virus, where there is an opportunity to prevent perinatal transmission through administration of immune globulin and vaccination beginning at birth. Syphilis, where an early intervention during pregnancy prevents serious congenital disease or death. Chlamydia and gonorrhea, where prioritization of follow-up on pregnant women with these infections can prevent pneumonia and other illnesses in newborn. HIV, where early identification and treatment can reduce the risk of perinatal transmission. Hepatitis C virus, where ensuring appropriate laboratory testing of the baby after birth to inform appropriate medical care. Influenza virus, where vaccination can be prioritized for pregnant women, generally more at risk for severe illness. TB disease and LTBI infection, where medications may be contraindicated for pregnant women and their fetus. With regard to the specific question before the panel regarding what core pregnancy information public health needs to know, my response is twofold. First, regardless of what data elements are collected, there must be guided policy that ensures these data are captured via coded and standardized value sets to the extent possible. This will support more accurate data collection and reporting and enable public health to automatically triage and respond to the vast amounts of information reported to surveillance and case management systems. Second, in terms of specific variables, at a minimum, public health needs to know whether an infected woman is currently pregnant, and if so, her estimated date of delivery. These variables may be captured as yes, no, unknown, and date fields respectively. Additional important data elements and corresponding coded values may include a current gestational age as a number of weeks or months as a unit and associated date, number of fetuses as a number, complications, prenatal diagnosis, abnormal ultrasounds. This information is particularly relevant for Zika virus, syphilis, and rubella infections. However, these data elements or findings may not be fully portrayed as coded values. Whether the pregnancy was terminated, yes or no, or if miscarriage occurred, yes or no, and a subsequent date. Current treatment for the infection of concern, standardized medication and dosage, and corresponding date. And finally, exposure date. In terms of when pregnancy-related information should be collected, it is dependent upon the type of infection under investigation. For example, with Zika virus, public health needs to know whether the woman was pregnant at the time of exposure, her estimated delivery date, and ultrasound results. For hepatitis B and other chronic infections, we need to know laboratory test results for every pregnancy. For diseases such as syphilis, the earlier public health knows about the infection during pregnancy and can intervene, the more likely a positive outcome for the baby. Accurately capturing when the mother was exposed and whether treatment was given is critical. Public health should establish the business rules for relevant infections to provide EHR vendors for clinical decision support activities. Furthermore, a collection of pregnancy information should not just be focused on collection and storage within the EHR, but across the continuum of care. In the current environment, public health has often taken action based on receipt of the laboratory test information alone. Having pregnancy information consistently present with laboratory results is critical for prioritizing resources and conducting interventions and follow-up. Laboratory testing by large commercial laboratories, hospital laboratories, and other testing facilities should capture pregnancy information and provide this information to public health. With regard to where pregnancy information is captured electronically, my only comments are that in my experience it is highly variable and not collected in a standardized manner. There is clearly a need for a recommendation standardizing how these data should be structured. Pregnancy information is critical for public health investigations, vaccination recommendation determinations, and prescription prescribing practices. To streamline engagements between providers and public health, it is important to consider both reducing the burden of reporting on clinicians and the timeliness of reporting. To the extent possible, data must be collected in structured formats following national standards. I would recommend the model currently employed by the Digital Bridge, whereby, for example, public health was charged with developing consensus upon a minimum set of data elements to be included in the initial case report. Public health and our partners should agree to what and how these pregnancy-related data elements may be standardized for inclusion in the EHR. Receipt of these data allow public health to prioritize resources and act accordingly to reduce morbidity and mortality. As we've seen in recent emerging public health threats, there are often rapidly
If you could please wrap up, Jillian.
Will do. Rapidly changing recommendations in the provider community to understand testing practices and public health follow activities. Automated tools that may be rapidly deployed for clinical decision support may help alleviate such confusion. The quick need to quickly disseminate public health information may most appropriately be done from a centralized platform such as the Digital Bridge. In summary, accurate and timely access to pregnancy-related information is a critical component of public health response. As we move forward towards full implementation of EHRs and the development of a platform to support public health reporting, articulating the minimal key variables and valuables and standardizing their format will facilitate actionable public health information. Thank you.
Thank you, Jillian, and thank you to all of our panelists on panel 1. We'll now take the time to have our task force members ask questions to provide further detail from your panel presentations. Just a reminder for those in the room, if you could use your tent card to raise your hand, and for those on the phone, if you could use the hand-raising feature to put yourselves in the queue. And since nobody's dying to ask a question, I'm going to call on Annie to ask the first one while you all think of your good questions.
Yeah. First of all, thank you, everybody. I'm sorry it's late. I'm really thankful to the panelists for coming and helping us understand these issues, really critical issues. So I do have a couple of questions. One is really, I don't even know who to call on. It's really mostly the local and state health, public health providers. How critical do you think it is to capture possible pregnancy as opposed to just definite pregnancy? That's one question. Second question is, how critical do you think it is to capture recent pregnancy? I know in New York City, many of the women that were exposed to Zika during pregnancy presented at the time of delivery and were only tested at that time or very soon thereafter. I'm wondering how critical you think that is to capture somebody who's just recently pregnant. And also, how critical is it to capture pregnancy outcome in general, just the date of the outcome, whether it was a live birth, stillbirth, et cetera?
Do you want me to? I could go first, very briefly. I'm going to put a little bit of my nurse hat on as well. And
this is Mary Ann.
Yeah, I'm very sorry. Mary Ann Cooney from ASTO. So from a possible pregnancy, absolutely, because of potential time of infection and the inability of laboratory results to potentially be accurate enough. The recent pregnancy, yes, because if someone is infected with Zika virus, they deliver, it's not unusual to have a second pregnancy that could immediately or very closely follow within the time period. And then lastly, pregnancy outcome. I think that the pregnancy outcome is essential for information for public health, and not simply just for the data and information about surveillance and research, but also the ability to make sure that the appropriate referrals are made, in particular if there's a birth defect, to the other agencies, sister agencies that would be responsible for the care of the family in these times.
Yes, I additionally have some thoughts. Aisha Haney, Harris County Public Health Chief of Disease Control. So I think there were several questions. So pregnancy outcomes. Texas has a pregnancy registry, and so they track all deliveries, including if there are birth defects, and they will follow for a year after delivery. So I'm not sure if that's available in all states or if all states have birth registries to track all births in the state. In terms of possible pregnancy, one of the things that I actually had in my initial testimony that I had to take out because there was a time limit was that, it would be nice. We get a lot of laboratory reports that are electronic laboratory reports of all testing that's done related to notifiable conditions. And so that's how we've kind of figured out that there have been a lot of missed opportunities, because out of all of the Zika tests that were performed in our jurisdiction, we go back, even if they're negative tests, and we contact the providers, we contact those patients, and we find out information about the test that was performed. And we found out that there were all of these missed opportunities and people who were not tested appropriately, wrong tests. And so we've had to go back, and sometimes we can't get an accurate diagnosis because the test, it's been too long. And so, one of the things that would be beneficial is if we know when someone is actually pregnant, if the electronic laboratory reporting system captured pregnancy, not just Zika, when a Zika test is ordered, if we know when people are pregnant, because we're also, as a public health agency, we're also going out and we're testing mosquitoes in our community. And so we will know when some of our mosquitoes test positive. So if we also know who is pregnant, or even the negative pregnancy tests, those are people who are at risk of pregnancy. So if we can match electronically the people who are at risk for pregnancy and the people who are pregnant in those areas of the county with our information that we have about mosquitoes, we can go then and target those pregnant women or women who are at risk for pregnancy directly that are living in the highest risk areas. And so knowing that information is very important. And as far as electronic laboratory reporting, it would require making pregnancy a notifiable condition, because that's the reason we're able to receive reports on Zika testing, is because Zika is a notifiable condition and labs have to report on that, and that gets dumped into our state health department laboratory reporting network, and then that comes to us. So I think you asked something else as well. Oh, so recent pregnancy status is important not just because these women can get pregnant again, which often happens very soon after a delivery. We see that many times, but also many of these women who have recent pregnancies are also breastfeeding. And so now we have, there's been a lot of research, and even though Zika is in breast milk, it's not been known to transfer to a breastfeeding child. However, that's the information we currently have. We initially thought that a woman couldn't give Zika to a man. And so, our information is currently is evolving. And so knowing, which women could potentially be breastfeeding. Also, what we found out this year is that although, we initially thought we would breathe a sigh of relief when someone would deliver and the baby had a normal head circumference, we now know that that is not a time to breathe a sigh of relief. We did have deliveries where, the provider said, no, we don't need to test, patient looks great, and so now, having to go back and look and make sure that those infants are okay. And so I think there are a number of things that we need to collect, even things that we think may not matter, because our information is slowly evolving and we may need to have that information in the future. Thank you.
This is Jillian Haney from Massachusetts, and I have two comments. One is that I think it is important to recognize, how much information is out there and what public health really needs to be prioritizing. I think it would be great if we could get a lot of this information that's being discussed, but in the real world, we don't have the resources to be able to respond to all of it. And I think identifying what those key minimal elements are that will prioritize our limited resources so that we can follow up appropriately is really critical. And the second thing is, there was a comment about making pregnancy notifiable, and I think that is a very interesting comment, but legally speaking, I think that would cause a lot of agita within state and local jurisdictions about making that happen. Thank you.
Thanks, Jillian. So in the room, I think Charlie actually had a comment first, and then Oscar.
Oh, I'm happy to succeed my turn to Oscar first to hear the local perspective, and then I just have something really brief.
Okay. Thank you, Charlie. To the question of how critical, possible, and definite in recent pregnancies, one of the things that we are tasked with is looking at health across the life course. And while this particular hearing may be focused on Zika, and as a result may seem to be categorically focused in that regard, having that data across that life course allows local public health to do a lot of things. And some of it, and unfortunately, people say, well, you epidemiologists want every bit of data possible. It's not that. We actually just want better quality data. So having the information as mentioned not only helps us from the perspective of a response to Zika, but issues that may pertain to perinatal concerns, issues that may have some overflow and cross-linkages with maternal and child health outcomes, and even women's health outcomes. So I would say that having that data, the information, doesn't necessarily cause much angst, but not having it essentially allows us to do nothing more than shoot in the dark and hope that we at least have the best available data to initiate some outcomes and interventions.
Hi, this is Charlie Ishikawa. Annie, thanks for your question. I just have a couple of things to add. I want to underscore the portion of the testimony I provided that is about using caution with this word capture and introducing new processes for capturing data. I think the data and the information are essential in that they need to be that public health needs access to them in one way or another is important. But how the data are captured, there needs to be caution there. And I think you can look to syndromic surveillance for examples of what happens when the method of data capture changes from free text to standardized drop-down menus. The other thing I wanted to point out is that there are answers to your question, Annie, in the attachment to my testimony, which has multiple quotes from persons associated with JFIT.
Thank you. We have lots of questions in the room now, and I think I saw Richard up first.
Yeah, thank you, panelists. This is Richard Loomis speaking. I'm curious if any of the panelists are aware of any consideration by the public health community around the feasibility of reflexive pregnancy testing for positive Zika results with appropriate consent from the patient at the time the Zika test is ordered. And is that something that that should be explored further as part of the work that we're doing?
So I think one of the things that we've implemented is a Zika screening tool that we use, and I printed copies out. We use that on all patients at all visits. It doesn't matter the reason for the visit, not just prenatal visit. Any type of visit they will be screened for Zika virus. In response to your question, the people that are being currently screened for Zika are A, people with symptoms, Zika symptoms, who need a Zika test, and then B, asymptomatic pregnant women. And so, given the fact that we're already picking and choosing who we're testing for Zika, doing a reflexive test, I'm not sure, because we're only testing people who are testing for Zika because they have symptoms or they're pregnant. I'm not sure where that would fall in. If they're pregnant, they don't need a pregnancy test. If they have symptoms, usually the person who is testing is already dialed into the fact that this person may have Zika, and they're able to give us that information on pregnancy because they're making sure, and they're doing pregnancy tests on them to make sure that if they don't know that whether or not they're pregnant. I think the main thing for public health is that, when we get reports from providers, we don't often know at the time of reporting. The provider knows, but we don't know. And so, without having to go back and get reams of paper that we have to then receive in fax form or whatever format, or from the labs have to even find out who the provider was, and it just takes so much time for us to find out pregnancy status. The provider often knows. We just don't know. So that would be the answer to that.
Hi, this is Mary Ann Cooney. By the question, I'm assuming you mean like a routine test for Zika?
No, I'm suggesting that if there is a positive test for Zika, would there be an opportunity then, and pregnancy status is unknown, is there an opportunity to then reflexively test for pregnancy in that patient if there is a positive Zika test, to provide that data that can then presumably be reported directly from the laboratory?
So I may get myself into a little bit of a trouble here, but I'm going to say that I think that it's good practice, actually, particularly in light of resources and resource constraints that may be present. But in areas where there is a higher risk, I think that testing for Zika should be a best practice with pregnancy, or even if pregnancy is not known, if a woman is of childbearing age. And almost extending that to the partner, if that's what the question was about.
Yeah, I think it's the reverse, that if there is in fact a positive Zika test, that then a reflexive pregnancy test would be performed in the event that the pregnancy status is unknown, such that with a positive test, there will be a positive or negative. And part of the reason I'm asking the question is because the only way to be certain in a patient of childbearing age to know that they are not, in fact, pregnant is to perform a test. So I'm curious if there's any opportunity to have, as part of that workflow, first Zika test, if positive results, then perform a pregnancy test as a reflexive test, as opposed to having to go back to the physician and order it if it wasn't already ordered at the initial point of ordering this.
So yes, I believe the pregnancy should be determined. And counseling obviously would happen at that time for partner notification as well.
I'm going to move us along just because there's a lot of questions now. Next up is Larry on the phone.
Okay, let's see if I can get it off mute and make this work. So, great discussion so far. I'm hearing a piece, so I'm going to step back, and the public health concerns, the actual health concerns, are clearly the preeminent issue. But I want to pick up on some of the implied technology and information flow that you guys have been talking about. So it sounds like the main information flow is from the lab to public health, and that there are lots of shortcomings in that information flow, things the lab just doesn't know. What's the current state of the art of reporting from providers to public health agencies? Is that happening in any significant numbers? Is it electronic? Is it coming directly from EHRs? So that we could be building on things that are already there rather than speculating about creating new capabilities. I'm looking to understand what's currently being done, so folks could comment on that.
This is Oscar from NACCHO. Two things with respect to your question. The vast preponderance of, the answers, it's pretty disparate across our nation, if I can say it that way. The question is really speaking to is, one, the ability for provider community to report those national notifiable diseases in each jurisdiction in a timely and a complete manner. We still have some jurisdictions that are receiving that solely by fax and sometimes by mail. And of course, there are others, especially the larger jurisdictions, who do have and the opportunity to receive that information electronically. By our recent 2016 profile data we just released a week ago, we can say from a technology basis that 79% of our health departments, across local health departments, are engaged in electronic disease reporting systems. In comparison to that, only 49% of them have electronic lab reporting, and 37% of them are tied into electronic health records, whether or not that be their own or access to the provider community utilizing that pathway for access to their EHRs. And then 17%, even smaller number, are engaged in health information exchanges. So that, of course, those numbers change very rapidly as you look between small, medium, and large-size health jurisdictions. But just to answer your question as succinctly as possible around the extent of technology and the implementation and utility of it.
And this is Aisha Haney, Harris County Public Health. So the majority of our reporting is via fax or via phone call. And so we do not have electronic reporting in Harris County. And, in addition to that, we're not always being contacted. And so, or we're being contacted at delivery. I mean, it's ridiculous. And so sometimes it's days after delivery, and we need to test both, mom and the child. And, you're supposed to test the child within 48 hours, and now where's that placenta? Oh, it's in the trash. So, there are lots of, problems, when it comes to contacting public health. We're usually the last person that they think of to call. And so automating that, having ways that there are connections from providers to the health department electronically where it's easy to do that, is so important. I mean, if that occurred, from a provider's office, and especially these safety net providers that are seeing most of our patients, then we wouldn't run into this so often.
In response to Larry's comment, which is, and it might be helpful for whoever's answering the questions to address this, is my understanding is now electronic communications between providers, the clinical world, and public health, the electronic connections are primarily lab reporting. And then in addition, some very few health departments have electronic provider reporting, but even that is known to be extremely incomplete, and it's often just a web-based form where you have to enter data, the provider has to enter data. So we know it's extremely underreported. So what I'd like folks to talk about too is, do we need an interim solution and then a medium to longer term solution such as Digital Bridge? So it seems to me that lab reporting is probably the way to go in the near term, and then moving on towards other types of connections like Digital Bridge. Is that a type of approach that might be something we should recommend?
So this is Charlie Ishikawa. Annie, I think that's an excellent point. I want to be cautious about the language that's being used here because I wasn't sure whether Larry was asking about all the different types of electronic communications between healthcare and public health, for which there are for which any of the connections that may carry a diagnosis or an observation or a note could carry pregnancy status information. So Larry, I heard you partially asking that question, for which the state of the art, you just looked at meaningful use and any of those connections that are being promoted, and Oscar offered you some information about the uptake there. On the other hand, if you want to talk about a reportable condition, then I think Annie's point about electronic case reporting and that electronic laboratory reporting is the state of the art for receiving those communications is spot on. And of course, as you heard multiple times here, there's a serious resource issue here.
And to underscore what Mary Ann Cooney, to underscore what Charlie just mentioned, is that there are very, very few states, in comparison to even the locals, very few states that have the ability to receive information from electronic health records, which would be ideal, and of course, in real time. There's significant delays. It could be weeks and months before state health departments may even receive, reportable conditions. Well, maybe not weeks and months, but certainly it's not real time necessarily outside of the lab reporting. The lab reporting is different, but in terms of condition, it would be ideal.
Yes, that really was what I was trying to get at, is how broadly there is a channel of communication from the providers who might have a more 360 view of the patient, not necessarily much more robust view, but often a more robust view, versus the high volume reporting that seems to be enabled for labs. And what I'm hearing is sort of today the high volume flow is around lab reporting, but there's emerging use of direct electronic links from the EHRs, but that's really limited, spotty, not something we could build on today, but something we could shoot for in the future.
This is Michelle. I'm going to move us along. We have lots of questions. So I'm going to ask our task force members and our panelists if you could be as concise as possible, because now we only have 10 minutes left of this panel, and we want to make sure we get through everyone. So I think Andy was up next with a question.
Unfortunately, it's half statement, half question. I'm wondering if I'm the only pediatric infectious disease doctor here in the room or anywhere in the universe of our discussion. I am. I spent a 30-year career dealing with congenital infections. This is not novel. But what we want to do is, I think, take advantage of what John White challenged us to do, which is there really were two issues embedded in his opening remarks. One, let's deal with Zika. But more important, and I think it's more important, let's not make this a one-off approach. Let's figure out what the process, an expedited, intelligent process for dealing with a public health emergency ought to be in a new electronic ecosystem. And to me, that means that all of the folks on the panel need to think about a very different question. Not what are the detailed data elements we need for Zika, but how is it that you are not going to drive delivery systems wild because in Harris County you're asking for one thing and in Galveston County you're asking for another. And you have different forms and different ways of collecting vital records. Because the delivery system is still in Houston or in Galveston, and it's the same people and the same electronic health record. So that's my statement. But the question is to be answered over the longer term. How are we going to use this meeting and the deliberations here to devise an effective process for responding to public health emergencies using electronic data? And what is it that we can do with the decisions about Zika that actually build the foundation that John was talking about? And I think what we're dealing with is, the consequences of a century of heterogeneity in public health jurisdictions, and we're trying to struggle to figure out how to manage our way through that. To be frank, I'm a bit cynical about Zika as an issue clinically, because there are lots of, as Jillian pointed out, many congenital infections that cause the very same thing. Somehow Zika got to be sexy because a picture of a Brazilian baby, went viral on the web. But that's just me being a cynic. Let's leverage it to make something good happen. Horses out of the barn with Zika. It's been a year. We're still not figuring out what we want to do, and we have a big task force, and we may or may not get to a solid recommendation from here. Let's do that, but let's make this work for these kinds of public health emergencies going forward. Let's figure out how to make this a model rather than a one-off. So please think about that. If you have immediate responses, I'd be interested in hearing them. But more important is you think it through from the perspective of your agency and your constituency to help us with ideas about how to do this in a uniform, logical way. Thanks.
Nature, if I may be graceful of responding. I respond not only as senior advisor of Nature, but also an individual who has spent 16 to 17 years as a local epidemiologist in the state of New York at a small county. The point that you raised in your question that you have put to our colleagues here in this board are quite interesting because public health has actually been excluded from being a partner in the front line of much of this health information technology advances, and as a result is actually operating from a disadvantaged position. The ONC, when it put into place many of the health information technology recommendations, did not include local public health or local health in much of that opportunities around incentivization and the building of infrastructure. You pose your question from the perspective of public health emergencies, but I think what we are actually trying to get across, it's not emergencies alone. Zika did come, but we still had all of our day-to-day 50, 70 diseases that we're required to respond to on a normal basis. So for every one case of Zika, we may have 70 to 80 hepatitis results that we're receiving. That's why the focus has been on at least developing a more streamlined commitment around electronic lab reporting. And what we've been saying from public health perspective is not a categorical one focus on a disease, but a comprehensive analysis on what can be helpful for us to do our jobs better in protecting the lives of those people we serve. So, for example, and I'll shut up after this. For example, the ability for us to look at data elements that a physician has, and that physician may be just looking at a patient and dealing with their clinical case definition. It's going to be different from an epidemiological definition. We're obviously going to defer to the clinician in the way they treat their particular client and patient. But we look at the community health perspective, and we have to address those public health needs and those threats that are arising not only from emergent infections, but infections that happen on a daily basis. So I would push back in that regard to say we're responding to the questions that were posed to us, but what you're asking is something that we've been saying from time immemorial.
I'm going to move
Charles
us on.
Ishikawa, brief response to Andy's question. A long-term solution that you should also pursue is looking at ways to combine and link different data sets that are out there.
Anjem?
Anjem Khurshid. And so the last comment was important because what I've been thinking in terms of one of the principles that this task force agreed for our recommendations was being pragmatic. And I think you've all described several challenges in terms of resources, other kinds of things. So my question was if there are these two things that we can do. One is to somehow change the workflow so the providers are reporting things that would be helpful in terms of identifying and managing these conditions. Versus what Charlie in his opening statement had also referred to, the ability to link data that is existing in terms of clinical claims, surveillance, etc. And we know both of these are challenges and challenging tasks, but several of you also suggested the capacity challenges for local health departments and public health departments to be able to, even when that information is coming, to link them. And there are as many challenges in terms of changing any clinical workflows because providers are already being asked to do too many things currently. So if you were to prioritize in terms of where our limited resources should be focused, or in terms of just even prioritizing in terms of timeline, what is short term and what is long term, what would your preferences be?
I'll speak to both issues that Andy brought up, as well as Mary Ann Cooney from ASTO. I think Oscar articulated it very well in times of limited resources, and we have just had an opportunity to ask state health officials what their priorities would be. Bidirectional data exchange might not necessarily be the one. And the reasons for that is there are a lot of things on their plate. However, when asked about the potential of bidirectional data exchange with electronic health record, they said it was essential to be able to determine the population health now and into the future. And I would also say that as it relates to Medicaid and the association with Medicaid with public health, that too is an essential element in being able to assure population health, in particular with those that are in rural and in community, particularly the populations, the communities that are suffering most impact. The impact is far greater. The inequities are far greater. And public health cannot today, in some instances, have a strong relationship with their Medicaid agencies. And it isn't by virtue of whether or not they want to play together. It's really the structures around them that might actually inhibit their ability to do so. So I'm sure someone else might have a comment.
I'm actually going to have us move on. Janet?
This is Janet Hamilton from the Florida Department of Health. And I think coming back to these issues of being very pragmatic and thinking about short and long-term solutions, to me, is critical in this conversation. I heard Jillian Haney talk about that this is bigger than Zika, and she gave a number of other diseases, and there's been some comments from the panelists about that too. And, when we look in Florida and we think about ELR, and this has come up in this conversation, our laboratory results that we are receiving today that have some indication of pregnancy status is less than 10%. And for Zika, it is less than 30%, even if you look at the women of childbearing age. And so I'm just wondering if panelists can comment on the criticality of receiving this information at this juncture via laboratory reporting, and what thoughts they have for improving that. For example, should pregnancy status be a required element that is responded to at the time of test order?
I'm sorry, go ahead.
Okay, this is Daisha Haney, Harris County Public Health. So a couple of things that I'd like to say is that our best source of information would be directly from providers and getting information in a timely fashion from them in a way that's easily accessible by us. That's the best source of information because it tends to be more real time when they do contact us. The ELR data that we receive, it is absolutely critical for us to have pregnancy status on that data that we receive. But, keep in mind for Zika, and I wanted to mention this earlier, by the time that we get a Zika result, knowing how long it takes to get a result for Zika, we have come down from months to get a Zika test result to now, weeks. Sometimes on a PCR, we can get that within, 24 hours, but we are not talking, real time. By the time we get those results, even though it's nice to get that, the patient's gone home, they've gone home from the hospital, we're not finding out that they've been tested until a long time afterwards. And so even though that's a reliable source of information, it is not the best source of information. The best source would be to have a way for providers to connect with us and for us to receive information directly from them. In addition, the laboratory should be, you get a 1-2 punch. You get the provider reporting and you get the lab reporting, and they're supposed to work hand in hand. We're having to rely on the lab reporting, which is, weeks, months after the fact by the time we get a result. But really, we should be getting very good information from our providers, which we are not getting because they do not have good EMR systems that have all of the appropriate linkages that they need to have. They should not have to go and, reach out to many other websites and to do in a single visit in order to accomplish something. They should be able to go into their EHR and have linkages that are appropriate and that help us out as public health departments.
Oscar from Nature. To add to that, looking at the short and long-term solution, I came from a state where locally I had access to electronic labs and electronic disease reporting system, and it helped for a couple reasons. Physicians, as was mentioned, clinicians were not reporting what their tests were. Having that simultaneous access, so when they did submit a test and the result went to the physician, there was a simultaneous result that was sent to the local health department. That enabled me to at least know what was out there, to then call the physician and say, why didn't you let us know of this, because this is a critical element. So that's one thing. And I recognize quite quickly that many of my colleagues across the U.S. did not have the benefit of that type of access. So that's somewhat why electronic lab reporting has been seen as an immediate short-term solution, because some are still receiving them by paper, by fax, and by the Pony Express. The other component for that is the recognition around pregnancy data and the quality of data that may be collected should be recommended because it has inferences not only on Zika but on other clinical elements. But we're also faced with the fact around the dichotomy around clinical data decision-making support systems and public health systems, which oftentimes may be at odds.
Final question to Susan McBride.
For Aisha Haney, you spoke to 800 cases and missed opportunity, or I believe estimated. I'm interested in understanding better the missed opportunity, particularly with the point of entry. And as we think about automated clinical decision support or standardizing where we capture pregnancy status, I want to understand that missed opportunity better. Mm-hmm. If we could standardize how pregnancy was captured. As you've looked at case studies, can you talk a little bit more about those missed opportunities? Mm-hmm. And is it ER? Is it our federally qualified healthcare clinics? Is it hospitals? Is it ambulatory?
To be frank, so the 800, it's 800 investigations. So it's people who have been tested that we go back and try to find out what is the scenario surrounding the testing. So it's 800 investigations of people who are being tested, that would also include our 39 infections and the 2 congenital cases that we've had that we know about. So the missed opportunities, they're at all, stages of pregnancy, all people being tested. And a lot of that we found out about because we were going back from our electronic lab reporting to find out what test was ordered, what was the scenario, and then we're finding out that the wrong test was ordered. Now we're going to have to go back and do the right test, but it's the wrong time now, and so we're not sure whether the result that we're getting is even an accurate, result. So in terms of where are we finding that out? That there are missed opportunities. We're finding out in the delivery room that the patient has been in care and has had multiple visits, yet no one ordered, a Zika test. Or sometimes a Zika test was ordered, but that didn't get communicated to the hospital. And that's why these linkages are so important, because a person can be in care, and yet because there's no linkage between that care and the hospital who's now participating in the delivery, which is a different person, a different delivery doctor, an obstetrician, from the person who is doing the prenatal care, there isn't a transfer of information. And so they're having to make on-the-fly decisions about, does this baby look normal? Or have you been, they ask very basic questions to the female who sometimes can't give an accurate, picture of whether they've traveled or not. And a lot of times there's a language barrier in addition to that. And so we've seen so many missed opportunities. It's very, frustrating because we see that as being avoidable, with better information exchange. So we've seen it in the delivery room. We've seen it afterwards, from providers that see see patients after delivery. We've seen it, prior to delivery, and not even just with pregnant patients, pregnant individuals that had symptoms that received the wrong test. And so we've seen it at completely across the continuum. We've done every 2 weeks, we send out Zika key updates through our Health Alert Network, which goes out electronically to all of our providers in the community. We update all of the information on what's new in Zika because the information has changed so rapidly. We include testing guidance as a part of that Zika update and any changes to the testing guidance because that has changed. So we're going out there, we're trying to be out there, but even with all of that, we're missing people. We're especially missing the ones that are serving the patients that are bearing the brunt of this disease, which is our low-income population that are seeing safety net providers that don't have access. They are not receiving our electronic health alert network communication, and so that's very frustrating. That's why I feel that we should be spending our money on improving those linkages at the provider level, beefing up their systems so that they can communicate with the places that are delivering their children, the public health departments, so that we can have the information that we need to have to do proper surveillance.
I think Annie wanted to make one final comment.
Thank you. I wanted to partly respond to Andy's comment and also to this conversation by saying that really we were charged with two things here for this committee. We were charged with trying to figure out this issue of pregnancy status and how should it be standardized within EHRs and then transmitted to public health when relevant, and then also the clinical decision support piece, which is more relevant to how do we enable clinicians and public health clinicians to make the right decisions from a public health point of view when there are public health challenges, whether they're emergencies or not emergencies, I think, and how do we make that happen leveraging the electronic health records. So both of those, I think, are a challenge, and I think they're slightly different. So we just have to remember that. I think we're trying to prioritize the pregnancy issue because we think it's somewhat perhaps achievable, and the clinical decision support we'd like to get everybody's opinions on and then sort of push this in a direction, but maybe not solve the problem here. And along those lines, I wanted to echo what Aisha just said, which is in New York City we had very similar issues with missed opportunities, people just coming at all stages, not recognized, not screened, and there were big disparities in those women who were not getting tested appropriately, and we did a lot of work to try to resolve those disparities. But I do think that electronic decision support would help with that, definitely. And then I also wanted to put out there the idea that pregnancy information is not just important to public health. It's important for clinical care. It's important for knowing what drugs to give somebody. It's important for knowing what vaccines to give somebody. It is important for healthcare providers across the spectrum, not just public health. So what I'm wondering, and one of the people who's going to be testifying later today did say to me, why don't we treat pregnancy like a vital sign? Why don't we collect it at the time of every single encounter of a reproductive age woman? Why don't we collect it just the same way we collect, do you have allergies to medications? Because it's important information for everybody to know who's providing health care or public health care for that individual woman and for that ultimate infant as well. So I just want to put that out there. I think there might be an argument to be made about at every encounter for women of reproductive age collecting a very small amount of information about known or possible pregnancy or updating the information if it's already known. So I just want to put that in people's minds to think about.
Thank you to all of our panelists on panel one. We really appreciate you sharing your expertise with us. We're running a little bit behind. We're going to take a quick 5-minute break just to transition over to the next panel. Thank you. Thank you all for joining us today. Just a reminder, you have 5 minutes. I will remind you. And I think we'll try and be as efficient as possible with our questions, both to you and as when you respond, so that we can try and stay on schedule as much as possible. We appreciate that. Thank you. So Virginia, if you're ready, we'll start with you.
Thank you very much. If you could show my slides, please. And thank you for letting me join virtually. I appreciate that. Next slide. This one. Thank you. So I just thought I would start by level setting everyone as far as what we understand are the laboratory reporting requirements. We understand that pregnancy is used as a status for determining and prioritizing testing that's going to be performed at a public health laboratory. And it's also used for surveillance activities that the public health agency will perform. Currently, we understand that the pregnancy status is used for Zika and hepatitis B surface antigen perinatal surveillance. Just a quick note on this topic is that during the Zika outbreak, the commercial laboratories were able to perform all testing that was received. We had capacity to do that, and there was no prioritization of samples required. Also, just wanted to let you know that pregnancy status is not normally required information for laboratory testing to be performed. We're able to perform many tests without needing to calculate in a pregnancy status date of estimated delivery or trimester in order to perform the testing. So this is ancillary information for the laboratory. Next slide. I thought I would describe two of the methods that Quest Diagnostics use to obtain pregnancy status for the reporting of both Zika and hepatitis B surface antigen. So for Zika, we incorporated an ask at order entry question onto the test order. And the question was just pregnant, yes or no. Using the LOINC code as our standard here, as was prescribed by the CDC, we were able to obtain the answer to that question as provided to us by the ordering provider. So this was something that we were able to add on to our electronic test orders, make it a required field, and we required this information prior to the order being submitted to the laboratory. Our other method was, prior to the Zika outbreak, was hepatitis B surface antigen, where we did not ask the clinician to give us any additional information. We used the information that's routinely collected on all test orders and used a cascading selection here described by first looking, was the patient female? If yes, then was the patient of childbearing age? And then if yes, was the diagnosis code that was provided, namely the ICD-10 code, indicate that this patient was pregnant? And if so, yes, report it as pregnant, as a patient pregnant. We also looked at if the patient was of childbearing age, was the test that was ordered something that would fall under an obstetric panel, such as the AMA obstetric panel. And if so, then we reported that patient as pregnant. We here are using the LOINC, the standard LOINC code for hepatitis B surface antigen. Next slide. I did think that I should mention some of the challenges in obtaining pregnancy status. We really have to require that the ordering provider supply us this additional information so that we can send it on to the public health agency. We've been told that providers have a limited time to submit information to the laboratory beyond what's required by CLIA. And there's really no incentive for the clinician to provide this information to the laboratory. There's no repercussion if we don't receive that information. there are issues that the laboratory staff does encounter when they have to go back and do follow-up to obtain the pregnancy status. It's really not a priority for a provider or their staff when we make a phone call to obtain the pregnancy status. They really do not appreciate us calling back to their office. Their office staff is very busy. If we have to
Virginia,
go back,
if you could please wrap up.
If we have to go back and obtain pregnancy status, it delays reporting to the public health agency. It disrupts the flow of automated electronic reporting and requires the laboratory to provide dedicated staff to this task. Thank you.
Thank you. I do want to note I was remiss in letting each of you introduce yourselves. So before you speak, if you could say your name and the organization you're with. Thank you.
My name is, can you hear me? My name is Carmen Pugh, and I'm from Laboratory Corporation of America, or LabCorp. First and foremost, I want to just let everybody be aware that a diagnostic laboratory's primary responsibility is to its customers. These are the patients and the clients who choose LabCorp as their performing laboratory. And one of the most integral parts of that relationship that we have with our customers is how information is exchanged. How is data exchanged between these two entities? LabCorp has three main categories that I've pretty much broken this down into. We have CLENDR, client-vendor interfaces. We have LabCorp product direct interfaces with our clients. And then we have non-interface methods. And these are all the manual methods that we receive specimen orders in, like manual requisitions, or perhaps we fax a result back to the healthcare provider. But these are the non-interface methods. So we have these three main types of categories of data exchange. And I feel it's important to emphasize that the method of information exchange is primarily determined by the client. So LabCorp is held within the boundaries of what a client can and cannot do. They choose the method of data exchange. And this applies to patient pregnancy status as well. So clients have to be willing and able to provide this information to us. And I want to stress that. Please understand, there has to be a willingness and there has to be an ability to even give this information to the lab. And once we are able to surmount this huge mountain ahead of us of just getting a client to give us this information, then we have to have the ability to store this information. All of the vendor interfaces have to be modified to be able to collect and transmit this information. The LabCorp interface has to be modified the same way. The manual requisitions all have to be recreated. All these processes have to be changed, not to mention all the changes that have to be done within the laboratory itself. The main LIS system, all the other branches of systems that feed into it. Anything that would potentially touch a pregnancy status would have to be updated, and this is huge. So I know that the easy answer is, well, yes, we'll have the labs do it. I want you to understand that there are multiple parameters in front of us that we would have to overcome. And first and foremost, that is a client's willingness and ability to give us this information. Now, we do have laboratory tests that require information on pregnancy, gestational diabetes, and alpha-fetoprotein. These are tests that actually require weeks of gestation. We collect this information in an AOE, and we store it in the test level. And that information is then used to determine the result, the interpretation of the result. And that information is reported back to the healthcare provider on our report. So we use that information. It isn't just a field that we're collecting, it's usable information. LabCorp currently does not collect pregnancy status. We do not store pregnancy status, and we do not report pregnancy status. But for public health reporting, there are three things that we do try to do to notify a Department of Health, Public Health, of a patient's potential pregnancy. Now, this is not pregnancy status, this is potential pregnancy. We will send through a clinician diagnosis code that's indicating pregnancy or prenatal or postnatal testing or experience. We have, anytime a test is ordered as part of a prenatal panel, we will mark that as being prenatal. Now, this is for all of our tests. It's not limited to just Zika. We're doing this on any state reportable test. But specifically for Zika, if a healthcare provider orders a pregnancy test concurrently with the Zika test, then we will report the results of both if a state is willing and able to receive that information. Ultimately, I strongly feel that it is the healthcare provider's responsibility. They are they're patient-facing. They have the clinical symptoms. They're the ones making the diagnosis. They have this information, and they're mandated to report as well. So it just seems that lately there's been a trend in public health to have laboratories, we'll just have labs report this. It's just the easy answer. But it's becoming a burden to laboratories to carry this. I mean, we are now being used as a public health information repository. We're asked to report results or information that we don't need for our testing. I feel that the efforts should be focused on improving healthcare providers' required mandated reporting so that moving forward, if we have another public health epidemic, that we won't be here in 2 years saying, well, let's see if we can get the labs to report this. Let's go ahead and focus our efforts on improving the mandated required reporting of healthcare providers so that next time there is a public health epidemic, we're safe and secure. We know we're getting the information that we need and everybody is doing their part. Thank you.
Thank you, Carmen. Julie?
Hi, Julie Lipke from the Mayo Clinic. Hello? Julie Lipke from the Mayo Clinic, a laboratory compliance office. We went through the panel questions and answered them as to how our systems work. To identify best practices for sharing pregnancy status, when ordering a lab test, the pregnancy status can be added by an AOE question. The ordering system should be able to send that status to the LIS in such a manner that it is readily available to downstream systems for reporting back to the client, provider, and public health. For ordering from an EHR, the pregnancy status should be available when ordering any test, such that the laboratory, X-ray, or any other procedure can have that status attached. This information could be sent to the LIS or other systems to have it available on the final report. How does data currently flow? In our external, that's our client providing, they provide the pregnancy status when on specific tests they answer the AOE question. The ordering system currently stores and sends that status to the LIS. If it's not answered, it cannot pass to the other applications such as the LIS and our reportable disease application. Unanswered questions delay completion and release of results. For our internal practice, pregnancy status can be entered and stored in the EHR. However, currently it is not available to the ordering system and it is not passed discreetly to the LIS. This would take a lot of IT resources in order to make this happen. Currently, the ordering clinician must answer the AOE questions for specific tests that require pregnancy status to ensure that this is provided to the lab. Mayo currently has multiple EHR software solutions, one of which does not provide the true order cycle for computerized provider ordering entry for laboratory orders. These AOE answers must be manually transferred to the LIS from the orders by technicians, which has to manually add these to the order, and that really takes time in the processing as well. What are the short-term, medium-term, and long-term solutions? Short-term, we currently have added new specific tests for hepatitis B on pregnant women and also add the AOE questions on our Zika tests. We could actually add these AOE questions to other tests, but this would add to our workload and also it needs to be added to the correct test. We could also add, like for syphilis, hepatitis, HIV, other tests as well. Pregnancy status should be available on case reports from providers, and providers should be able to report this status to the public health departments. For medium term, we add AOE questions when ordering a test which asks the pregnancy status. This is a result and answer, and question and answer, and the result is in the OBX. Example is this patient pregnant? Is it yes, no, or unknown? Our long-term suggestions would be to update the ELR, the EHR, and LIS systems to have a special place for pregnancy status that can be electronically sent, stored, updated, and sent to the ordering and downstream systems for availability on reports. This would be for both our internal and external lab reporting tests. Standardization in reporting for all lab reporting is essential for this to be completed. Should standards be developed to address pregnancy status? Yes, we feel that it is very important for pregnancy status to be available on reports, as it would provide information for treatment and services if needed. This would include all tests such as HIV, hepatitis, syphilis, anything that would need pregnancy status. In order to comply to standards, stakeholders need to address the limitations of LIS and EHRs to be able to store and pass this information. There would need to be a way also to update the status in real time so the pregnancy status is always accurately when the test is ordered. Is ask at order entry a good short-term solution? Currently, Mayo uses AOE questions for all Zika tests. These questions are asked when these tests are ordered. The answers are reported back to the provider and public health. The process is not fully automated at all times, and some manual intervention is required to actually add these answers to the LIS. Currently, we use Lincoln SNOMED codes for these questions and answers. By adding these AOE questions, this extends our test implementation time, and also we still have the question for our internal to add these manually. Mayo Clinic is a hospital, clinic, research facility, and reference laboratory. Has a unique perspective on the value of providing patient information in a timely and meaningful way. This information can be extremely important in the treatment as well as
Julie,
management
can you please wrap up?
of patients' health. The ability to share and exchange information is a vital benefit to public health and other public agencies for surveillance and management of diseases and illness. Mayo Clinic's ultimate goal is the needs of the patient come first. We look forward to working with public health to achieve this goal. Thank you for this opportunity.
Thank you. Kelly?
Kelly Robleski, Association of Public Health Laboratories. The Association of Public Health Laboratories represents 56 state and territorial and 42 local public health laboratories, so it's important to recognize that public health laboratory approaches to and capabilities for collecting demographic and epidemiologic data is incredibly varied. So some of what I'll state on current data flow represents the ideal, and Mary, who will follow me, will talk specifically about how this works in one public health laboratory. Many labs still rely on paper test requisitions, from which data are manually entered into the LIMS, and rely on faxing or other manual reporting mechanisms. So we do fully recognize and support the idea that informatics capabilities across the public health system need to be improved. Despite inefficiencies in data collection methods, public health laboratories in general reliably receive and report pregnancy status when that information is of interest to a particular pathogen or condition. However, that is, as I stated, quite variable, and the variability in approaches between public health laboratories at this point make adoption of standards quite challenging. So, that being said, representing those laboratories that do have fairly sophisticated electronic capabilities, pregnancy status is ask on order entry, and HL7 version 2 messages use OBX segments for AOEs, which is associated with LOINC and SNOMED CT codes. From the lab to the public health authority, these can be included in the electronic lab report using HL7 version 2 messaging. From the test provider to other providers or the public health authority, and these are found in summary documents in social history section of the problem list. And then, as I stated, the challenge really is that not all public health labs report test results using HL7 messaging, and there is an awful lot of reliance on manual data entry. So should there be standards to address pregnancy status? I think the short answer is yes. I do think it's very critical that you establish the data elements that are required versus those that are desired for public health laboratories. As has been stated by these other panelists, there is a tremendous burden put on laboratories to collect a lot of these data elements. So prioritization from public health departments is key. The department and determining if data is just for exchange versus stored and retrievable for future reporting analysis. And I think that there is a question that needs further discussion on can you use these same standards for both of these purposes. So what should those standards address? yes for pregnancy status, yes for postpartum status or recent delivery, and gestational age, I think maybe. I understand that it's important to public health. I'm not sure it's really appropriate for the laboratory to be responsible for collecting that sort of granularity of data. Ooh. Solutions to improve data sharing. So short-term solutions: define standard vocabulary for data exchange, define standard locations for elements in HL7 version 2 and the CDA. Medium-term solutions can be harmonized vocabulary solutions across data exchange when standards are used, if not already done in the short term. Identify data elements, representation, and associated vocabulary and storage. And then over the long term, standardizing data element representation across storage and exchange, and allowing reasoning against data elements for decision making. Thank you for the opportunity to present.
Thank you, Kelly. And finally on the phone, we have Mary.
Hi, this is Mary from the Wisconsin State Lab of Hygiene, and as Kelly said, we are a public health lab for Wisconsin. And currently we do have a field in our LIS for pregnancy, yes or no, and we also have a field that does, that we can put in the expected delivery date. So those are the two pregnancy fields we currently have. If we receive that information by paper, as Kelly said, we do a lot of paper requisitions. We do enter it into our LIS. If it's electronic, we can get it, we can consume that. Currently, we don't have anybody who is giving us that information. Our current status for Zika is we don't test any Zika unless it is already approved by the state public health department. So they get a lot of the information on paper, and that paper is sent to us when the specimen is sent to us. So the state public health department works with the providers and the hospitals to get that to us. And that is all entered into our LIS. And we do have the capability to send that information to public health. As of now, through ELR, as of now, they're getting the information first, and they are putting it into our Wisconsin electronic disease surveillance system. And then we send all results, negative and positive, through ELR to that system. So that's the way it's currently working with Zika. So again, we do have the capability to consume that information if we're given it both on paper, or we do have electronic orders, and we can use that data. And then we can turn around and send that through HL7 to the public health. As far as should standards be developed, yes, I agree. I think they should be developed. We do have to keep in mind, as Kelly said again, that providers, labs, hospitals, and health departments do have varying capabilities to send, receive, and also consume that extra information that we're sending to them or receiving from them. And again, we do document in our LIS whether they're pregnant, yes or no, and then the expected delivery date. As far as ask it order questions, currently we don't use them. We don't have, as a lot of them are paper recs, we don't have ask it order questions. We do have the capability to do that. And for our electronic reporting, again, if we receive it, we can consume it and turn around and send it. But we don't use the ask it order questions at all. Thank you very much.
Thank you, Mary, and thank you to all of our panelists. So again, we'll ask for the task force members to put yourselves in the queue with your 10 card, and we'll start us off with Annie.
Because I'm going first again. So nice to meet some of you who I've spoken with on the phone a few times. Our partners in especially the commercial lab sector and also APHL. I have a question for the commercial labs. It was very helpful to hear from APHL that a small proportion of public health labs have the ask on order entry option. For the commercial labs, both Quest and LabCorp and Mayo Clinic, I'm wondering what proportion of test orders do have the capability to require the information at the time of order entry? Is that just for electronic test orders? Do you have paper requisitions also? I'm just wondering, like, how much of the segment of testing that's done, let's just say for Zika, is actually getting this ask on order, or is it all of them?
This is Virginia Sternfeld from Quest Diagnostics. The Zika test is currently the one test that we do focus on for the ask at order entry question, where it's ancillary information that's not required for any sort of test result to be prepared and sent back to the clinician. So Zika is currently, we require it on electronic orders, and we can have it on paper requisitions also. Although the majority of our orders are electronic. Thank you.
This is Carmen from LabCorp. Our Zika testing, primarily the IgM, I don't remember about the nucleic acid amplifications. One of the requests that we have is that we do get pregnancy status with our orders, and that would be sent through the interfaces, through HL7 or in the manual requisition. But the way that we receive that information is through the clinician rendered diagnosis code. It's not information that we need to perform the test. It has no outcome on the test. You still get a positive or negative regardless of whether the patient is pregnant. It's not like a gestational diabetes panel or glucose tolerance test. There's no information that we need. So we will still perform the test, but we just acknowledge that we do not have a pregnancy status or a diagnosis code indicating pregnancy. It's not in the best interest of the patient or the provider treating that patient that we hold off on testing while we wait for a piece of information that we really don't need to perform the test. So in terms of, what's the percentage of the different types of orders that we get, it's about, I would say 60-70% of our orders are coming through interfaces, and about 30 to 40% are manual requisitions, our manuals.
Stephen Jewell, Mayo Clinic. This is Stephen Jewell, Mayo Clinic. So from our standpoint, the majority of our Zika tests are electronic, and so there's a requirement at the ask order entry to complete those questions. In fact, as they are completed, they are immediately resulted back out to the Department of Health if they are hooked up to our ELR feeds. Last time I saw all these people, I met with Janet, and we sorted that out because she's explained to us very clearly we need that information up front because if someone's been traveling or someone is positive, we've got to get the mosquito guys out there to his neighborhood. So Julie and I went to the bar in the hotel and sorted that out with the labs. The bottom line is that the communication needs to exist between the commercial labs and departments of health, but the incentive has to be there that was put out there for hospitals and providers as well. As a hospital, we went through the process of making sure that we fulfilled meaningful use and did all the things we had to do. But as a reference laboratory, we have over 400 laboratory clients with 600 plus sub-clients, so 1,100 individual interfaces that would have to be updated and customized to fulfill whatever their individual client requirements are. So I think that's where your gap exists. We can add ask order entry questions to any test. We have lots of tests, as Carbon put out, where there are components that are required for the resulting piece. But in this situation, for public health, we can require it, but it has to be useful.
Thank you. I missed the order, so I apologize. I'm going to start with Janet and go around.
So this is Janet Hamilton from the Florida Department of Health, and I wanted to start by really saying thank you for coming to this. I think we all recognize that it's not just one group, that the consciousness of us all, public health, the clinical community, laboratories, needs to work together across the continuum. And I think so I very much appreciate you all being here today and participating on the line. I would also say, just to bring out a thread, I think we heard when some of the public health partners were making their comments that doing this well and right takes work, and I think we heard that from the lab too, and it will take resources, and I think we all fully recognize that. It's thinking about the partnership that is important. I would also just comment that as we think about this and we think about clients and patients, that the reason why we're here is because we are trying not just to help inform public health, but improve client care and the continuum of care, and because each of the individuals has a responsibility in that, that's why we're hearing from these different groups. So while I have heard some comments that our clients maybe do or don't want X, Y, and Z, I would also really encourage us to think about that by making changes, we are making recommendations that will actually improve care across the continuum. And then I think the question that I'm interested in hearing a little bit more about, which I've heard, is actually two specific questions. One is there were some comments made that the recording or capturing of pregnancy information delays the results. And so I would like to hear a little bit more about that and the thinking behind that. And then the other thing that I'm still trying to tease apart a little bit is there's been some discussion about interfaces with clients and then separate ordering practices that are non-interface based. And so I think I understand the non-interface based aspects, but for those where there is an interface, is pregnancy information via that interface captured in any sort of required way for Zika testing? So I think I understand, right, when there's like web order entry and someone's completing something, that's one piece, but it's that sort of lab to client automated interface. If you could talk a little bit more about that.
Stephen Julian, Mayo Clinic. So part of our test implementation process with our client laboratories involves direct testing of those tests as they are added to the patient catalog or the client's catalog. So a component of that test build is the ask order entry question and verifying that the test comes across, the answers are legible, and they are received and stored appropriately. So in those interface solutions, that's as we introduce the test, the client builds it. They have a test environment we're connected to all the time. They have a tester of the day within our SQA department that goes ahead and verifies that, and they validate the completion of those tests. From our web order entry component process, you're exactly correct. There are prompts that pop up, and very, very quickly they're aware of that. Even for interface clients, we have a client-facing system that sits between their LIS and our LIS, which allows them to batch their daily tests and also verify that they've gathered all the components, print the labels that are required, and verify their batch. In there, we'll not release the batch until the ask order entry questions are complete. And so that way we verify and perform that. It does not delay the performance of the test. The specimens will still get in the box. They still go to FedEx. They still arrive the next day. But they cannot close that batch and complete their processing so that the next day they can just keep going. So it keeps the process moving forward without stopping the processing of those tests.
And I'm sorry, just to follow up, is that really because of the way that the LIS is structured, though? I mean, I think we do get updated results, and so would that just be another sort of change to consider and think about?
This is an intentional process we've put in place because of the fact that we're aware that we don't ever want the information being omitted from stopping the processing of the specimen, as Carmen alluded to. But we also want to make sure that when we deliver those results that we're able to provide all the information that's required from a clinical standpoint or a public health standpoint, because we are required as a reference laboratory, just as the provider, to report to public health. And so if our record is incomplete because they haven't completed it, then we have to make sure we get that. So we have a staff that calls calls the provider, fulfills that information. Internally, it's a little different. We did mention some delays that are involved in the process of capturing that pregnancy information, but that's more of a logistical thing with regard to the fact that we currently support multiple EMRs across our enterprise, and so that some have a full order cycle and some do not. And so if you don't have a full order cycle, it's impossible to sort of insert questions in there and get them answered appropriately. So there's a manual component involved in that, and that does delay the process of getting that order in there. We've made processes and policies to accommodate that and ensure that doesn't delay the resulting of that. But again, it's a point of information for you folks, because while we at the Mayo Clinic have the ability to be nimble in lots of areas, some other smaller hospitals don't have that capability. And so it's important to take into account that there are limitations with the EMRs, whether what version you're on or what components you've purchased will directly affect your ability to perform these things quickly and efficiently.
Thank you. Richard Loomis?
From Practice Fusion. I have two questions. One is a specific question, and then one is a more a broader, more macro question. The first is, across the industry, what's the ability to pass through with the results pregnancy status? So if it does make it through from an ask at order entry or through the electronic transmission as part of the order, what is the ability, again, across the industry, to the best of your knowledge, to pass that through to public health agencies along with the results of the Zika test? And then the second question is, as was mentioned earlier, if we focus too narrowly on Zika and pregnancy status, we miss the opportunity to have an impact for future public health reporting emergencies and even just day-to-day public health work that the industry undertakes. And so my question is, what should the task force be considering as ways that we can think beyond specific pregnancy status or Zika related aspects of this challenge and think more broadly? Stephen, you had mentioned modifying 1,100 different interfaces. Obviously, we don't want to be back here next year with the next public health emergency suggesting that another 1,100 interfaces get updated again. So, thank you.
If you don't mind, Stephen from Mayo Clinic, I'll take that to begin. And keep in mind, the 1,100 interfaces is just our side of it. And so that translates to our expense or our investment of time and resources. Each of those clients, whether they be a single physician or a large multi-practice or a hospital, also have that same requirement to make those changes. But to answer your question about pregnancy status and particularly how it pertains to Zika, I think we have to be careful to attribute this as being the solution, the Zika component as being the solution to providing pregnancy status, because what we're doing is we're asking a specific question and we're storing an answer. And the question I would have to the public health departments is, how easy is that to surveil and trend and keep track of in your systems? Because I know they're different, each one, and they're not as well standardized as EHRs are. And I think we heard in the last panel that the access to EHRs from that group is very limited. And so while in our health records, we have a component that does say pregnant, yes or no, that is not the same as this ask order entry question we're talking about. And in our LIS, while that component I spoke of in the HR exists within the patient visit segment of messaging, our LIS doesn't have a place to store that. So that doesn't currently translate to something that's useful from an EHR standpoint to an LIS standpoint, and then downstream to a public health department, because what we're doing is we're saying, yeah, we can capture it here, we have nowhere to use it here, we have to pass it down there, and so our best way to solve that is that we'll just ask the question each time. And that works to solve public health emergencies and individual cases, but I don't know if that solves public health's problem of keeping track of, was this person pregnant when this happened? Is this person still pregnant? When is this person going to be pregnant again? And maybe focusing on, as Dr. Weisenfeld said, focusing on this Zika component isn't going to solve our overall solution of how do we make sure that all the pieces in this puzzle have all the same information. I don't have an answer for you other than to say that we need to, if we've focused on the top-down scenario, and I think Oscar brought it up, saying, no, they love the fact that we focused on electronic laboratory reporting because it gives them that one piece of information that's quick and easy and fast, and we do it that way. You know, when I met with Janet at the Fin conference, you know, turnaround time was 4 days, best case for a Zika virus result. We're down to 24 to 48 hours, so it gets better. But if they're not connected at public health, if we're in Harris County, they get some of that ELR information, but not all of it, or the physicians aren't connected, then we're not solving the problem. And so we've got the standards we built, but I think we need to sort of come back from the bottom and build up and find some way to meet in the middle.
This is Carmen Pugh from LabCorp. I agree with Stephen in what he said. Even though currently LabCorp does not collect, store, or report the pregnancy status, it is possible. I mean, certainly, you know, we have a saying between me and my IT group is if you throw enough time and resources at it, anything is possible. We can do this. But the level of effort for one data element, you know, we have to take that into account. Yes, it would have a huge improvement with public health. But, you know, as I said in my statement, we're going to be back here in a couple of years, and we're going to be discussing the next data element you need. And so laboratory testing primarily collects the information that it needs to do the test. So we need the patient's name. We have to have a date of birth and gender because we use those for reference ranges. We may need some billing information. We do need billing information, of course, but we don't need pregnancy status. It's just not something we need. So what we're being asked to do is modify hundreds of systems to be able to store information and report it back out. Could we do it? Are we willing to do it? I would say yes. I would not be able to put a time frame on it. It could be months. It could be a year. So, you know, it's a long term. And then we'll be back here again with the next, you know, epidemic and what data element do you need? And then we'll go through the whole thing again. But we have to weigh the request to change our systems versus what is it that we need to do for the tests, the other tests that are being created, new tests that are being performed, not just Zika. So I have to stand there and say, okay, please, IT, can you add pregnancy status? Can you make a change to all of these systems? And they have to weigh that versus, okay, well, now we have this other new test that's come about, and they need to have certain fields. What's more important? Is it more important to go live with this new life-saving test versus efforts and resources in adding pregnancy status, which we don't need? So I'm not saying we can't or won't do it. I'm just saying there is a huge effort involved, but it is entirely possible.
And
thank you.
This is Virginia Sternfels from Quest. Just to add on, your first question was about the fact, do we pass this information on to public health agencies? And I would have to say that any information that's really in our LIS systems can be captured and transmitted to a public health agency. However, that being said, that whatever the decision is on ways to either collect or provide any of this information in the future, I just request that it be in a standardized fashion, and Quest would not be in favor of this remaining as a ask at order entry question. We don't find that to be the best solution. Thank you.
This is Mary from the Wisconsin State Lab, Public Health Lab. Currently, we store a lot of things in our LIS that are important to public health. We store travel, we store exposure dates, we store the pregnancy, and anything that we store in there, we can turn around and then send it to through ELR to our public health partners. So some of it is already built as a matter of we store it, but unless they specifically ask for it or want it, it's stored, but we can turn around and send it to them.
Thank you. We have lots of questions. So again, I'm going to ask everyone to be as concise as possible. I'm going to go to Larry on the phone.
Hi there. Thank you. Lots of good discussion. A couple of feasibility questions based on some of the earlier things we've heard. So we heard about a desire to have additional provider and patient demographics so that when the LIS does report, that public health knows how to get a hold of the right doc, the right practice, or the right individual. So maybe you guys could talk about that. And also there was some comments made about using logic in the EHR for the hepatitis B to determine pregnancy status, and I'm wondering if people could talk about the success of that approach. So sort of two questions bundled together.
I can address at least the logic and the EHR. I don't think that is really a feasible solution for most public health laboratories at this point.
But that was done in the EHR, right, to capture that additional information? Or was that strictly within the lab side?
That was Quest Lab.
Yeah, Virginia, was that done in the EHR or was that done in your system?
That was done in our own system. So for, like I said, all the information that we have on hand, we can set up that logic, that cascading criteria to select test results that are reportable and determine if potentially the patient was pregnant.
Okay, but the scope of information would be just what came with the lab order, what the diagnosis was, and things like that.
Right, with the routine information that's sent with the test order.
Okay. And on the thought of having additional information about the patient or the requesting provider so that public health has a quicker channel to get back to those individuals, is that something that the labs are currently tracking, or would that also be additional info?
This is Carmen from LabCorp. Every time that we receive an order, backtrack, the majority of times that we receive an order, it is associated with an account number for our client. And that information is stored in our LIS system. So for state reporting purposes, when my files are being generated, we actually extract our client information, including the ordering provider and all of the address, phone number information assigned to that client that is stored in our information. We do occasionally get orders from healthcare providers who do not use LabCorp as a client, and this is an issue. It does cause a delay in reporting, but it also causes a delay in us reporting the results back to the healthcare provider because we have to try to find a way to do so. So not every healthcare provider is a LabCorp client. Everybody has select labs that they like to use. And so I think all the laboratories in general try to accommodate any test requests they get. But within the LabCorp system, it's all based on an account number, and the order that we receive is tied to that account number. So the information, for the most part, is always available. I hope.
So this is Virginia Schoenfeld again. Yes, I have to agree with Carmen. Our accounts are set up, that information is obtained for our clients, and we report that to Public Health Agency. I think you may have also asked about patient demographic information.
Right.
That seems to be the most difficult in obtaining because the provider usually doesn't want to take the time to give us demographic information, namely address, if we're not going to bill the patient, And so most of our billing is going to third-party vendors and insurance companies and as such. So having that patient demographic information is very difficult to obtain.
Well, both Carmen and Virginia in that situation. We do tie back to a client account, but that doesn't necessarily take into account who the actual provider was. There are many times where we won't receive the actual provider information, so we'll have to default back to, Joe's hospital and say this is where it came from. Then it'll require a telephone call from ourselves or from the public health department to find out who that information is. And as I mentioned earlier, the 1100 interfaces, so everybody has gone through, or not everybody, but many of them have gone through the 251 upgrade, but we have not had any upgrade to our inbound interfaces from clients. And so much of the patient demographic information is available, but there are some components that are available in 251 that are not translatable to 231. And so we have some gaps that we're working on to update in that process. It's, again, part of the top-down scenario that makes it more difficult to know what we can pass back from the bottom up. So there's some disconnect in how to incentivize a commercial lab to make those updates.
Thank you.
Thank you. Susan McBride?
Yes, this question is for Quest Labs and perhaps clarification on LabCorp's part. Virginia, it sounded like you had a nice, mature process for ask on order entry and to capture pregnancy status, yes or no, with the LOINC codes. But it also, I believe you indicated that you had missing data and that it was the responsibility of the providers to actually give you that information. So I want to dive into the missing data issue and also, and explicitly, where do you get the largest proportion of your ask on order entry? Is it ambulatory versus hospital? And if you have missing data on one side or the other, more commonly, which is it? So that's one question I have. The other I have is Quest Lab seems to have a pretty mature process, and yet LabCorp spoke to difficulty with the different client-vendor direct interface and more interface methods, paper-based. I would expect that Quest Lab has similar kinds of challenges, and so I wanted you to speak to that, priority being that proportion of ambulatory versus hospital, though.
I have to believe, and I don't have the exact, and I think I'm hearing an echo. Hopefully that's better. I would have to believe that the majority of times, because we have our AOE questions as required before the order can be submitted electronically, that we're getting that information from them. I think where we might have the most difficulty in obtaining that information, and because not given is also or unknown is also a response to some of our questions, is that in a hospital environment, the hospital laboratory that's actually ordering the test may not have information that's actually in the hospital system. So they cannot pass, they don't have sometimes connectivity to obtain all the information that's actually in the hospital system to transfer it through their hospital lab, LIS, and then onto our ordering. So that's where I know where there's sometimes difficulty.
Thank you. Julia Gunn?
Thank you. I continue to hear that you don't need the pregnancy information to do a Zika test, and you're being asked to collect a lot of more information than you would usually need. So my question is, have you considered this within the framework of HIPAA, privacy, and other legal issues? And if so, what have you learned? And if not, is this something that we should put on the agenda?
This is Virginia Sternfeld again from Quest. All I can say is that when we discuss HIPAA and privacy issues, we know that when we're dealing with a public health agency that they are considered a covered entity. So they will follow all the HIPAA requirements and confidentiality of this information. So that has not actually raised a concern for Quest at this point in time. If we were to potentially randomly request it for every single test, that may raise a flag, but I can't say that we've had an issue at this time.
This is Carmen from LabCorp. An example that I can use that it's very similar to this issue here are blood leads. We're required to collect race and ethnicity, and those are data elements that we do not need. It's strictly being collected for surveillance purposes, and there is an extreme amount of difficulty in collecting race and ethnicity. It's virtually impossible for, especially today's day and age, for a mother to indicate which race her child is. This is information that's very difficult to collect, and there are a lot of healthcare providers, a lot of our clients who cite HIPAA that this is not needed. You don't need this information to perform the test, and they are correct. But we do work to try to collect that information because it is mandated, and public health is covered under HIPAA. I get a lot of health departments telling me that they're exempt, and that bothers me because you're not exempt. You're covered under HIPAA. So you are allowed access to this information as long as it's information that's needed, and it's detailed in the state regulations. For me to be able to provide information, I need to be able to show why I'm providing this information. So it certainly helps that what you're asking for is a field that's mandated. And I hate that I said that because that's what's going to happen. But it helps us in terms of compliance and being able to say, well, this is a requirement, this is a mandate, this is what we need to do.
This is Julie from Mail. I agree with Virginia that we added the AOE questions mainly because it was a CDC guideline to add them for this information and for the continuity of care for pregnant women that have Zika. So it was very important to get that information to the health department so they could follow up. And also if it was a travel-related, especially for Florida, because that's where we had a lot of Zika cases, as Janet was telling us when we decided to put the AOE questions. When we resolve those as preliminary, they immediately can go and put mosquito control or whatever they need to do in those areas before the result. So that is the reason why we chose to do that, and we have no problem with reporting the pregnancy status on that, as Virginia has mentioned.
Thank you. Annie?
Thank you. So a few things. I wanted to ask a few more questions, but I also wanted to hearken back to what Janet had talked about in terms of the partnership between public health and the laboratories. And one thing I wanted to say is that at least in New York City, and I think it's becoming more true across the country, is currently we are completely, incredibly grateful for the work that the laboratories have done to report to us electronically. It is the mainstay of our disease surveillance efforts, and with those data, we are able to do so much to help improve public health in our jurisdictions. So I just want to thank you for all the work that you do and recognize that it isn't your business to do it, but you are doing it because it's required and also because it does promote public health. So I think the elephant in the room is that there is no real funding mechanism for that, and I think our federal partners need to think about that because you are one of our partners, and we have to find a way to support and continue to support that type of work. Then secondly, I wanted to mention that to ask a question, well, there's sort of an elephant in the room in that this goes back to the short-term versus long-term solutions, which is that, yes, we would love to be able to get more data, better data, more complete data, all kinds of different data elements, travel history, et cetera. And I, for one, recognize that we can't force all that into the laboratories to be able to give it to us. We have to get it eventually from electronic health records or from patients themselves somehow. Some of this is not even in EHRs. So ultimately, we do want electronic case reporting and electronic data reporting from EHRs directly to public health. But the truth is that is not going to happen immediately, and we are in the initial stages of figuring out how to do that. There is a gap in terms of probably years before any public health agency can get that in accurately, completely from EHRs for a range of diseases in production. That's just going to take a while to build it. So we're going in that direction, but now we don't have it. So this is why I do think that right now the labs are our critical partners in terms of being able to get this information. And at that same time, we need to figure out how to do it in the most judicious, minimal way that poses the least burden on the laboratories, but provides the most juice for public health. So that's what I think we have to bear in mind. And along those lines, I wondered, also why are different diseases handled differently? Why would hepatitis B or syphilis, or why would pregnancy information for those diseases be handled differently than it is for Zika? Wouldn't it be more efficient to sort of try to get it across the spectrum in the same way? And could test type be used? Should those tests always have a prenatal option, so that at least knowing that it's a prenatal hepatitis B test, it's a prenatal Zika test, it's a prenatal syphilis test, that would convey that person is currently pregnant? Is that one way to do it?
This is Carmen from LabCorp. What you speak of is one of the things that we're attempting to do just with our public health through the clinician diagnosis codes and the indicators that a test is part of a prenatal panel. We recognize that pregnancy is needed for multiple infectious diseases, and so we do not limit it to any one particular organism or disease. So we do pass that information on. We are relying on the states, the health departments, to tell us what information they need for their surveillance purposes. So you tell us that you need pregnancy status for Zika. If it's within our power and it's approved, we can find a way to do that. We can collect that information, we can store it at the test level, and we can report it as an OBX segment in our HL7. And yes, we can do that. The issue, though, is that we've now included a piece of information in that patient's test record that the healthcare provider already knows. So if I'm going to report to New York Department of Health and state that this patient is pregnant, I am now including that information on my patient report back to the healthcare provider. And he doesn't want to see hepatitis B surface antigen, your patient's pregnant.
Can I just make one comment?
Certainly.
Which is that actually our finding in real practice is that these providers change all the time, and sometimes they don't know that their patient was pregnant or is pregnant.
But they have to tell us.
Sorry?
They're the ones that have to tell us.
No, but sometimes they're seen by a different provider. So just to be aware that the test results might go back to a system, and that information might be useful.
Understood. From my understanding, for the most part, the healthcare provider that orders that test is the one who's viewing the result, not to take into account the reference laboratories. And I'll put some thought into that. But when we store information on that patient, that information is reported back to that healthcare provider, and it ends up creating a patient report that's clogged with information that they don't need, that they don't want to see. So, like I said in my statement, is that that's our primary responsibility. That's the most important relationship we have, is with that ordering client, that healthcare provider, and we want to give them a patient report in whatever format they choose to get it in that's user-friendly, that they can look at, they can make their decisions and go on. We don't need to bog it down with information that, for the most part, they already know this patient is pregnant. So, yes, we could do AOE questions. We could store pregnancy status at the test level. We could report it with the Zika. But we found that it just made, in doing so, it would make the patient report a lot more difficult, and we didn't get good reception when we reviewed that.
Anne, it's Virginia Stonefeld. I understand the option that you're putting out there regarding having a prenatal version of a test available that the physician can order. But I just want to remind everybody that with Zika testing, it was more than the labs being requested to provide pregnancy status. There was like 4 other questions that we were asked to obtain information on. Region where the patient lives, was there travel history, so on and so forth. So I just wanted to say that Zika was a little bit of a different type situation than just asking for pregnancy.
This is Julie from... Okay. One point I want to make is I think where we really need to start is standardization in reporting. And by that I mean the diseases that are reportable, if they're positive, if they're negative. We have tests that have 20 filters on with different ways health departments want us to report. And that's the complexity of, reportable disease reporting. If we had a centralized place where we could go and get the requirements and what is needed, that we could standardize our systems, that might help in the whole process to standardize your systems. And Carmen and I have talked about this for years, and we bring it up on the national ELR call. We bring it up all the time, and one state goes, no, I want this, no, we have to have it this way, I don't want less than 10, I want greater than 20, and it's just like a dog chasing its tail. So I think that's a really good place to start to standardize reporting altogether.
I'll put my 2 cents in, Stephen at Mayo, but I think we're talking about the difference between the science and the standards of care, and I think that's where we have to find out how you, as the government, are going to sort of draw that line. Which side of that line do you want to fall on, and how do you control or enforce that, or do you want to? Because if I go for a particular test, and she goes for a particular test, and he goes for a particular test, does it matter what race I am or whether I'm male or female? Sometimes. But for the most part, standardized testing is standardized testing. And if we go and say, well, we're going to make a panel for this and a panel for that, I'll go back to my 1,100 clients. They're not only clients of mine, they're clients of hers and clients of Virginia's. And because no one just says, I'm going to go with one reference lab. And so we all add a new prenatal panel, and it includes a Zika, and it includes a lead, and all the other things we want. They've got to build all of those, each of those panels, in addition to each of the individual tests, and they have to test them and verify them. And who's going to control that? We can keep doing this, but we're never going to get to the end of it. We're making a bigger pile out of the discussion than just saying, well, what's the science? How do we report it? And then what are the standards of care we have to perform afterwards?
Okay, we're running short on time again. So I'll start with Steve, and then we'll go to Janet.
Previous suggestion was made that easy way to solve this is just to run a pregnancy test. You've got the tube of blood. Beta HCGs are cheap. I'm sure you all have comment fields in your results for whatever lab test. The test is hemolyzed, the blood is clotted. There's got to be a comment field that would not require a giant change of interfaces. Just would like to hear you guys respond to that suggestion.
This is Carmen from LabCorp, and this is a question I've had to answer quite often, so I'm going to jump in first. We are mandated by CLIA to only perform the tests that are ordered by the healthcare provider. We cannot, just because it's the right thing to do, perform a pregnancy test on a patient. We're not allowed to. There are regulations. CLIA does not allow us to do this. There are fines associated with this.
You do an FTA on an RPR that's positive, right?
But see, that's the test that's ordered. So LabCorp it depends on what the healthcare provider orders. We have a standalone RPR. We have a standalone RPR that reflexes to a titer if it's reactive. We have one that will reflex to an FDA or a T-pallium antibody if the healthcare provider ordered that test. Now, to answer, I think, probably the meat of your question, should there be a test that reflexes to a Zika test that reflexes to a pregnancy test if positive? I think that's a good idea. Logistically, it can be a nightmare. We have to get the patient's gender. And we have to have the ability to say, okay, this patient's female, let's go ahead and reflex this, because the healthcare provider is going to order a test on a male because he's going to order the wrong test.
But you've already stated gender you have.
Say that again, please.
You have gender.
Not always. It's one of the fields it's quite difficult to get. Back to what I said, there has to be a willingness to provide this information. And it's very difficult to get healthcare providers and clients to give us any patient demographic information, especially if it's what we call a client bill. If we're billing that healthcare provider for the laboratory testing being done, there is very little cooperation in terms of providing patient information to us. So we would have to create a panel. We would have to have a system in place that says, this is a male patient, you order the test that reflects to the pregnancy test. We have to call, we have to say, we believe you ordered the incorrect test. We want your permission to switch to just the Zika test. So already there's a built-in delay. So I think theoretically it's an excellent idea, and I'll go back and actually take that to the discipline directors and ask what the feasibility of doing something like that is. But it's like I said, we just can't do the test because we're not allowed to.
So, Carmen, of course, you're correct, Virginia. And, we all have to follow the CLIA regulation. I just wanted to put out there on the table, there was a statement made, Steve, and I hate to contradict you, but you say pregnancy is a relatively cheap test, and, you know, maybe it is or isn't. There's a lot of moving parts to get a test ordered and performed and reported. We'd also have to think about who's going to pay for that test. Would insurance companies or health plans pick up the payment for that test? Just to throw that out as part of the.
This is Kelly from APHL. Public health laboratories don't routinely perform pregnancy testing, so it would be a whole new test that they would have to add to their menu.
Okay, I'm going to move us along. Janet?
Thank you so much, Janet Hamilton from Florida. And my questions actually fall kind of in line with this conversation, which is, you know, at the state public health lab, our experience in Florida has been that many times that the test that the provider has requested actually was not the test that should have been ordered. And what I mean is that the person's time from when they were exposed to determining the correct test actually is very important. And so I think one of the things that we have been very concerned about, and certainly from an ethical perspective and other things, is, you know, when you recognize that because we have some other additional information that's epidemiologic information, and we recognize that actually the client could get information that's incorrect for them to think about from their own health perspective. So if they get a negative PCR test back and they think they've been tested for Zika and they're negative, they may not actually seek the appropriate additional care if they had an IgM test that was done, which would actually indicate infection at an earlier point in time in their pregnancy. So the public health lab does function, I think, in somewhat of a different role than the private clinical labs, where those laboratorians are actually reviewing all this information and then following up with providers to give them an indication that perhaps a different order should be placed, and then actually, from a public health perspective, doing different kinds of testing. And we do that all the time. And I hear the issues around CLIA and other things, and I think that it is important to say that, you know, public health and clinical laboratories do play a different role and have a different set of responsibilities. So in recognizing that, though, I think we also can think about the fact that clinicians have a huge amount of information to take in during rapidly evolving events, and for all of the people that they see on a regular basis to make the best decisions that they can at that point in time. And I think we also recognize that clinicians want to make the best decisions, but there's a lot that they have to keep or stay abreast on in order to make the best decisions for ordering and other things. And so I'm just wondering, from the lab's perspective, what your thoughts are on trying to help them make better decisions. So, for example, if you recognize that someone's pregnant and, you know, only one test is ordered, but another test should be ordered, would you want to help your clinicians make better decisions? And what you see your role in that going forward. And I think this kind of gets into these sort of short versus long-term recommendations and how people consume information and make good decisions.
This is Mary from the Wisconsin State Lab. So what we do, and we do recognize when they are not marking the right thing, but currently for Zika, our state public health directs the testing on what tests should be performed and then gives that information to the provider. So they have to call for approval, and then the tests are normally marked correct. We do still find a couple that aren't, and we actually call the state public health department and say, is this really what should be tested? And it may change or that they may not, but that's how we do it currently. If it got to be tons and tons of testing, I'm guessing that probably wouldn't go because they wouldn't have the time to work one-on-one then with the providers.
Okay, we're very short on time, so I'm going to turn it to Margaret, and then Larry has a quick comment, and then we'll go to public comment, and then lunch.
Thank you, Margaret Lampy from CDC. Just one comment related to Zika is that pregnancy status is important information for labs to have so that they can do the appropriate reflex testing. So that's just one thing to put out there. Secondly, I was really curious, particularly from the commercial labs, how your pregnancy status reporting by mining, which data are you mining to understand that an obstetric panel was done? Is it only data like obstetric panels that are ordered in conjunction with your hepatitis B surface antigen test, for example, or can you look at your previous test done on a particular patient to know? How do you use that obstetric panel data to then determine that somebody is currently pregnant? Does it have to be done at the same time?
This is Carmen from LabCorp, and to answer the one statement that you made about we need to know pregnancy status for reflex testing, that goes back to, again, we can't perform a test that's not ordered by the healthcare provider. So it has to be ordered, that reflex has to be ordered. And so we would perform that test irregardless of pregnancy status because that's what the physician ordered for the most part. I want to qualify that.
So they would have to wait for the results and then say do the reflex testing, or they would have to order the initial test and say also do reflex testing based on the result? How is that done?
This is Julie from Mayo. Our test catalog has that information, so when they order a test, they know it's going to be reflexed if it's a certain result, say positive or
for a pregnant woman
titer.
Specifically.
Excuse me?
For a pregnant woman, because it's slightly different. So
yeah, because we have separate pregnancy panels, prenatal panels
for Zika. Yeah. Okay.
So right. So there's an online test menu available. It has all the descriptions of the test and all the reflexes. We actually even provide LOINC codes to any healthcare providers and vendors within that online test menu. And so they can go in and they can choose which test. And once you're established, once that healthcare provider is established with LabCorp, they become familiar with the test that they want. And we also have the option or the ability to create client-specific panels. So if one particular OBGYN wants a certain test, then we can set that up for him, or he can order the ones that he chooses. And within that inherently are the reflexes. So they can order the panel that has the RPR that reflexes to the FTA, or he can do the one that doesn't. It all depends on the test. So there are thousands of test numbers. What was your question about the prenatal?
The second question was, thinking about ask on order entry perhaps not being the most practical. And a number of you mentioned that you utilize the ordering of other tests, such as the obstetric panel, to flag women as being pregnant for hepatitis B surface antigen result reporting. And how do you do that?
Within the online test menus?
The basis of the question really is how sensitive and specific is that for you? And
with the online test menus, we indicate when a test is prenatal. So a healthcare provider can go in and put in the search word prenatal, and it can bring up all of the prenatal panels. And then within the state reporting system, when I state report that, I know that this test, because of the test number that was ordered, I know that this hepatitis B surface antigen, this HIV genius, or whatever the case may be, I know that it originated from a test number that is known to be a prenatal panel. And in doing that, that allows me to actually put the word prenatal. But there are some issues with this. We don't limit our prenatal panels to females. A healthcare provider can mistakenly order a prenatal panel. So we're not saying this patient is pregnant. All we're saying in our ELR files to the state is this was from a prenatal panel. And it's just another, hopefully, some information that they can use to say, we need to determine, is this patient truly pregnant? It's our way of just trying to provide the extra information.
Margaret, this is Virginia Sternfeld. Just Quest does it differently than LabCorp in this regard. We don't have set up multiple prenatal type tests availability. So that's why we use, I showed that cascade, and that's how we can determine for prenatal, but we're only doing that cascade, that review for hepatitis testing, because we don't have a separate prenatal hepatitis test. So that's why we're using that structure.
Virginia, does the prenatal panel and the hepatitis test have to be performed concurrently to be included, or could it be from a month ago, like from a first trimester obstetric panel, and then?
We cannot link back to previous accessions or samples that we might have received and tested, and that's why we also look at the ICD-10 code, because that would remain constant, hopefully, at Cape pregnancy.
Great, thank you.
Could I just ask a quick follow-up question on that, the issue of this is Annie Fine, on the ICD-10 code. So can you just explain that just a little bit more, because why is it an ICD-10 code that is part of the test order, or is it an ICD-10 code that's a diagnosis in the EHR? How do you get an ICD-10 code, and is that happening with all test orders? I'm just a little bit not understanding that piece.
The ICD-10 code is sent over from the provider because it's normally used and routinely used for billing purposes. So we're able to look into our billing system to determine the ICD code that's being, and it could be more than one code that they send, but we look for the codes that indicate pregnancy. And like I said, that wouldn't be normally routinely used on the clinical side just for testing purposes. It's being sent for billing purposes, but we're cross-functioning, we're cross-referencing that into our ability to report to public health agencies.
So the laboratory uses it for billing purposes?
Yes. When we have to bill insurance companies and or health plans, we have to include a diagnosis code in our claims.
This is Stephen at Mayo. So things differ slightly here because we tend to segregate billing components from clinical components in those regards, so we wouldn't see that as an option. I think it's also important to mention, because a number of you have asked this, do you get that information from the EHR? And as a reference laboratory, we don't connect to any of our clients' EHRs. All of our connectivity is directly to the LIS, and so we are always limited by whatever connectivity exists between that LIS and the client's EHR. Inpatient, for our hospital things, we have all kinds of connectivity to the EHR. But even still, that's also limited because we again are interfacing to our LIS, and so while there are limitations that exist between what the industry traditionally passes back and forth between LISs and EHRs, so that there's an assumption from lay people that, it's all in one building and you have access to all this data and you can just get it. And that magic doesn't exist, and I need you to write that down. Magic doesn't exist, okay? Can it be done? Yes. Before I worked for Mayo, I was over in England working on their national EHR. Their plan was to use a different standard for messaging. It's an HL7 3.0 version. That's an XML-based transmission, which gives you the X means extensible, because you can keep adding components and tags on there. We in this country have stayed in the 2.x area, which doesn't give you that flexibility. Every standard has to be gone through a committee and agreed upon. Everybody says, okay, we're going to do this one data element like we're doing today. And the bottom line is, if we don't move to a standard that is extensible, we will continue having these meetings about, hey, can we send freckles or not? Right?
Okay, I'm going to wrap us up because we're running short on time. Larry, do you still have a question?
I do. I'll make it short, and we'll see if we can get a quick answer. So we've been diving into the specifics of how lab information systems work, and my earlier question was really trying to understand if the logic was happening on the ordering side or in the lab system side, so I'm glad that all got clarified. But as we look at the informatics of this, it's clear, at least I think it's clear, that the lab systems don't try to maintain a single patient identity across time, across possibly even multiple lab tests, that they're really focused on single sample, single specimens, getting specific lab tests run, getting those resulted, and then that ends that sort of unit of information, and they're on to the next one. So it's sort of a sanity reality check here that the labs are not looking to manage a single patient identity. Right?
That may be not quite true. This is Virginia from Quest. We are seeking ways to link by some sort of unique patient identifier so we can, in the future, do an over time or link back to other sessions, either the test results or what other tests have been ordered. So we are working towards that. I wouldn't be surprised if the other labs aren't trying to do the same thing.
This is Carmen from LabCorp. Very similarly, we are working on a system, but this is actually patient-based, so they have to be able to go in and request that all of their lab tests be available to them in one patient portal. And so we assign a local patient identifying number to that patient, and then all of their information is available to them in the portal. But this is an external product outside of the LIS, so we don't have the capability of saying we had this patient 8 months ago, it's the same patient. LabCorp has 500,000 sessions on a daily basis. So trying to maintain and link all of those patients to past orders that we received on, that patient. How many Carmen Pews are there? There's actually quite a few. So it's very difficult thank you, Stephen. It's very difficult for a reference laboratory to link their patients. It's a little more simple in a hospital laboratory because patients are assigned a medical record number when they're within that hospital. And that information is stored in their system, and every time that patient comes to the hospital or gets lab work at the hospital, it's tied to their medical record number. But reference laboratories are laboratories for all the hospitals and healthcare providers, and it's much more difficult to assign a medical record number for linking the patients. We would run out of numbers.
Essentially, every accession is a new patient. There are methods within patient portals to go ahead and find your own information and tie it together. But we even have struggles when our own Mayo Clinic patients go to hospitals within our health system and get reference lab work and trying to tie that back together. Without a national identifier, that's not going to happen, and I don't see that occurring easily either. So the thing is, we have to rely, again, on standards of care and making sure that our providers are following their own rules to get information passed around efficiently.
Okay. Thank you very much. I'm going to thank all of our panelists from Panel 2. We really appreciate you sharing your expertise with us. We do need to open up for public comment before we go to lunch. So if there is anyone in the room who would like to make a public comment, please come up to the end of the table next to Mary's name, and we'll share a public comment. And while we wait for somebody to come up to the table, if, Jim, you could open the lines.
If you're listening via your computer speakers and would like to make a public comment, dial 1-877-705-6006 and press star 1 to be entered into the comment queue. If you're currently on the phone, just press star 1 now and you will be placed in the comment queue.
So it looks like there's no one in the room that has a public comment while we wait for those on the phone. We are a little bit behind, as I'm sure you've all noticed. So we'll probably steal from our task force discussion time because we do have time tomorrow. So we'll adjust the agenda accordingly. But we will come back at 1:45. So panel 3 will be a little bit delayed. There are some folks on the phone, but hopefully that won't change things too much. So it does look like we have a comment on the phone. So before we break, looks like we have Mari Savickas from Chime. Go ahead, Mari.
Thanks so much. This is Mari Savickas with the College for Healthcare Information Management Executives. And I joined the call late, but I noticed that there was a tremendous amount of conversation around being able to appropriately identify patients to their records and challenges with multiple portals. And I just wanted to highlight again that this is a key piece for interoperability for the entire healthcare system, and that with respect to the labor H ban that's in place now that precludes HHS from spending money on implementing a solution, it doesn't preclude them from working collaboratively with the private sector who is trying to locate solutions. And Chime has a $1 million challenge to try and address this issue. So for anyone who's interested, we have a website that's herox.com/patient ID challenge. So, and everyone has my email over to ONC, so I'm happy to take questions on this, but it's something that we encourage HHS to continue to work collaboratively on. Thank you.
Thank you, Maury. Okay, and thank you again. We'll come back at 1:45.